Welcome everyone to join us in MobiHealth 2020. This year we have a fantastic set of submissions which cover a wide range of interesting areas, which includes 20 topics on remote health assessment, public health system design, new mobile and wearable sensing technologies. We would like to thank all our authors for their excellent work and contribution to the conference. We wish them success in their presentations. This year, it is our great honor to introduce two keynote speakers, Professor Pan Hui and Professor Annie Hessami. Professor Pan Hui is currently Director of the Media Lab at Hong Kong University of Science and Technology. He is also an International Fellow of the Royal Academy of Engineering, a Fellow of HVE, a Distinguished Scientist of ACM. He will give us a talk to look at the future of mobile phones in sensing health conditions. Professor Annie Hessami is currently the Director of Research and Development and Innovation at Vega Systems, based in London. He has an extensive track record in system assurance and safety, security, sustainability, knowledge assessment management methodologies. He will give us a broad context for the consideration of ethics and values in the exploitation of emerging digital technologies, and also elaborates on the IEEE initiatives in this socially and globally sensitive context. So you can find the keynote speech schedule on the conference website. We are all looking forward to both of the talks. So in the end, we would like to thank all the chairs and TPC members who are dedicated to delivering fair, in-time, and high-quality reviews. We also like to thank European Alliance for Innovation EAI that organizes and manages the conference so that we can run the conference so smoothly. To that end, a special thanks to Christina, who has assisted us tremendously.
ladies and gentlemen, let me welcome you to the EAI MobiHealth 2020, the 9th EAI International Conference on Wireless Mobile Communication and Healthcare. My name is Kristina Petrovichova and I'm the Conference Manager of MobiHealth 2020. Unfortunately, due to the COVID-19 emergency, I'm not able to meet you all in person. Therefore, I'm using this opportunity to address the organizing committee, the keynote speakers, the authors and participants on behalf of the European Alliance for Innovation. Thank you for being part of this conference. In particular, I would like to thank the General Chair, Professor Yuan Ye from the University of St. Andrews in the United Kingdom, and the General Co-Chairs, Mr. Michael O'Grady and Simon Jobson, together with the whole organizing committee for their hard and excellent work throughout the whole process of conference preparation. During today's event, there are truly many ways how you can actively participate and enjoy the online interaction. During the streaming, there is a Slack platform available for all the participants where you can discuss the presentations and participate in Q&A sessions. Upon accessing the link below for MobiHealth 2020 workspace, you can enter all channels which are divided into sessions. Moreover, you can vote on individual presentations and leave your fellow presenters' feedback via EAI Compass. In a moment, we will show you how you can access these platforms and make the most out of this unique online experience. I would also like to use this opportunity to invite you to join us for the next edition of MobiHealth in 2021. We will keep you updated and the news about this event will be available on the conference website. Should you be interested in becoming a part of the next year edition organizing committee or the technical program committee, please do not hesitate to contact me at my email address available below. In addition, if you are interested in organizing an event with EAI, such as a conference, a workshop, or a seminar, please do not hesitate to contact me at my email address as well. I will be happy to provide you with more information. Now, our community manager, Michal, will talk more about what EAI does, who we are, and how you can get involved in our various activities. Thank you for your attention. Enjoy this conference.
Hi everyone, my name is Michal Dudic. I'm the Community Manager at EAI, European Alliance for Innovation. It's my pleasure to welcome you at this conference and say a few words about who we are and what we can do for you and your research career. In short, EAI is a global community for a greener, healthier, and smarter world. As of today, we are home to more than 60,000 members from 167 countries, and we reach out to tens of thousands of subscribers. As an organization, we are non-profit from day one, and what is most important to us is that we remain open to all researchers from all around the world thanks to membership that is completely free. We organize more than 100 events annually, such as this conference, and we do so in publishing partnership with Springer. I said in the beginning that EAI is a community, so let's talk about what that means and what it means for you. To put it briefly, we give our members a platform that builds their research. We do it with 3 main online community services where members come together to help each other write a better paper, get an objective review, and get recognized fairly. The 3 services in question are EAI Compass, Community Review, and EAI Index. Firstly, EAI Compass is an online app where you can meet and connect with new colleagues and get feedback on your paper as well as your presentation. In addition to that, it lets you download all full papers that will be presented at this conference, and you can vote on your favorite presentations as well as see everyone who is here and connect with them. You can do this right now if you go to EAI Compass website, compass.eai.eu. Next, we are improving the classic conference review process with community review. It has already been in use at all our events since 2019, and we were very excited to hear a lot of positive feedback from program committee members regarding the reliability and the speed of the community review. Let's talk briefly about what community review does. Essentially, it is a website that shows abstracts of papers that are right in the middle of the review process, as long as the authors allow it, of course. And all EAI members may then bid to review specific papers. When they submit their bid, they put in their bio and their qualifications, which are sent to the program committee, who can then decide whether or not this bidder is qualified to review the paper they bid on. This relatively easy access to review opportunities means that bidders really need to put their best foot forward if they wish to be selected, which improves the quality of the entire review process. At the end of the day, this benefits you, the author. And last but not least, let me tell you a thing or two about EAI Index. EAI Index is our credit-based evaluation system that we rolled out this year to all of our conferences and journals that allow you to climb the global ranks of EAI community and get recognized for your work. It calculates a number value for most actions you make, such as getting your paper accepted or submitting a review, and these numbers accumulate for 12 months. At the end of this 12-month period, we put together a ladder of all EAI members, and the ones at the top receive a nomination to one of the membership ranks: senior member, distinguished member, or fellow. For each action that is eligible for EAI Index credits, we'll look at the quality of your action as it was evaluated by another member of the community, such as, for example, the review score of your submission. To make sure that the system is fair to newcomers, every 12 months the credit count gets erased, the ones at the top receive their nominations, and every member starts at 0 for the following 12 months. And finally, Smart Submit is a collaboration feature that is coming later this year. It will allow you to submit your research ideas and your work-in-progress abstracts to get the kind of help and feedback you're looking for. Maybe you are looking for co-authors, maybe you would like to find a mentor or a mentee, or maybe you want to find out how the community feels about your idea. This is what Smart Submit is designed for. Ultimately, it's about helping you write a better paper and increasing your chances of getting accepted. Again, we will be launching this feature later this year, so stay tuned. And so I'm going to leave you with many different ways to get engaged at different levels. There are lots of opportunities in many of our events and publications, which means many ways to connect with people and collaborate. You may learn more about everything I just talked about at our website, eai.eu. These services exist to help you and to make your lives easier, so we encourage you to send us your comments, ideas, and feedback to community@eai.eu, And if you're interested in volunteering and contributing, you can let us know at the same email address. Don't forget that you can use EAI Compass to vote on presentations in real time to determine which ones are the best, as well as to download all full papers that will be presented today. Just make sure that you log in using the same email address as the one you used to register to this conference. Thank you very much for your attention. Please enjoy the conference, and I hope we will see everyone online soon.
Hi everyone, welcome to my talk. My name is Pang Hui. Today I'm going to talk about a look at smartphone data for sensing health conditions. This is joint work with my team and also some external collaborators. And first let me give a brief introduction about the context. So smartphone have become a very important device, or maybe to many people, it is the most important device in our daily life. We have been using smartphone for many purposes, right? For example, checking emails, doing social networking, and even a lot of multimedia functions. So since everybody have a smartphone, and today, and people are familiar with the smartphone, but we can also have a look at the details about what actually inside the smartphone. So we can see, you can look, we can see from these figures on the right, that smartphone, it have a lot of different sensors. So we have the compass, we have the cameras, we have the magnetic sensors, we have the light sensor, we have the GPS, and a lot of other things like the Wi-Fi, cellular. They have accelerometers, have orientation. So it's kind of a very smart device with a lot of different sensors. So because of this sensor, right? So the smartphone can continually collect data, monitoring user behavior, and usage behavior, which means the usage of different sensors, different interface, right, at real time, and provide user with feedback and recommendations. So let's say that what data the smartphone are collecting. So we can divide them into kind of three type of data: the hardware data, the network data, and the software data. So for the hardware data, we have the CPU usage, the memory usage, the GPS trajectory. For network data, there's network connections. So basically say what kind of network connection you are using now, like whether Wi-Fi or 3G or 4G, and also the traffic consumption tell you how much traffic actually your network interface is generating, right? That basically how much data is you are accessing this network interface. And for the software data, they have application usage records, so it tell you that what app that you are using and how much actually data, how much CPU, how much memory that your app is consuming. So and then also app management behavior, etc., etc. So basically the smartphones have numerous embedded sensors enable we say that the passive collections of user data, and then in making the smartphone a particular promising self-monitor tool, and for a lot of study as well. So in our recent work, we explore how to use smartphone data to sense people's health conditions. As that we have just mentioned, they have so many sensors, right? That it can actually act as a very useful tool to collect these health-related data as well. So in this talk, I will bring two examples. One is for group condition sensing. Basically, how can we use the sensors, from on the smartphone to infer some of these, information about the COVID-19, right? Including, for example, the outbreak stages. I'm going to talk a bit more later about what this means, outbreak stages, and how actually we collect the data and how the data are used. And the other is the framework called HealthWorks. Basically, is a machine learning framework to using the telco mobility data to kind of predict the health condition of the users. Okay. I hope and you enjoy the talk. So let's start first with the COVID-19 of the smartphone usage. So we first make the effort towards understanding the impact of COVID-19 on smartphone usage, and then we try to explore the potential of the smartphone usage data to fight against COVID-19. So, but this talk, we're not going so deep into how we can fight with the COVID-19, but we say that whether we can just use this information, the smartphone usage to gain more insights about the COVID situation. So at the beginning of 2020, as all of us know already, that we have been suffering a lot this year. So, but since the beginning of the 2020, COVID-19 was identified and has spread globally, and now it's a pandemic that many people have been suffered. The outbreak of COVID-19 have greatly changed the world as well as a lot of our behavior, right? You can see that probably these days we are advised to keep a social distance from our friends. We are advised to stay home, to work from home, right? So those are the behavior changes, caused by the COVID-19. Therefore, we in this study, this kind of more preliminary study, we aim to answer two research problems. The first one is whether and how the outbreak of COVID-19 affect users' smartphone usage behavior, right? Whether there's any effect at all, right? But we try to, if there's effect, how are the effects? And then we can the second that whether we can use this smartphone use data to infer some of these outbreak stages of COVID in real time. So these are the two kind of research agenda for this COVID study. So first we look at the data, okay, because data is always important for data-driven study, right? So in this study, we leverage a crowdsourcing platform called Keynote to collect the smartphone usage data. So Keynote is cross-platform, we mean cross-operating system mobile app, including both iOS and Android. It was first developed by University of Helsinki and also UC Berkeley, and now kind of mainly managed by the University of Helsinki team. So Keynote was developed as a kind of energy, a battery kind of advising app. So basically, it tells you which app is using more energy. And you want to save your battery, maybe look at your phone, right? That you see that your battery currently is only 15%, right? And then you estimate that you still want to use your phone for another 2 hours. Then Keynote can tell you which app to switch off because this app is using a lot of energy, or it also tell you that which app may have some energy bug that it is particular energy hungry or battery hungry in this case, right? But then since the launch of this app, that it became very popular and it had many download and install. So now we can also use this app as kind of a tool for study users' behavior. Okay, so in order to, but we have to say that we are kind of very serious about the privacy issue. So I would like to first mention how we protect the user's privacy in this study first. So in order to protect the user's privacy, we only collect and leverage the non-privacy sensitive data like CPU usage, memory usage, and network connection type, right? So and when the when the user install the Keynote, right, that the Keynote actually will inform the users on what type of data will be collected, and then you also strictly follow the end user license agreements, the EULA. So Carla cannot or will not collect any personal information. Also, all researchers, working on this data set are regulated by a very strict non-disclosure agreement in order to access the data. Okay. So in this work, this COVID work, we primarily consider the sample collect from the USA, where most people have suffer from coronavirus outbreak, unfortunately. Yeah, and another reason is that there are a lot of US users in our data set as well. That at least we want to get a kind of large portion of user in order to draw some statistical meaningful results. So in this data set that we use, we have 452 users and have over 7.5 million records for this period of November 2019 to April 2020. Okay, and they have an normalized user ID, timestamp, CPU usage, memory usage, network status. So but it does not have any, as you see that it does not have any sensitive personal information over there. Okay, and then we the next step is that we have to kind of determine the output determine the outbreak date of the COVID-19, right? So because we want to get the data and divide them into the before outbreak and then after outbreak. So we regard the March 2020 as the outbreak date for COVID-19 in the USA. So how we determine, basically we put the data into the figures here, right? And then and you can see from the figure that it show the basically it show the cumulative number of confirmed cases in the USA, and we can see that the case here is is February and it is March. March is here, right? And we can see that the cumulative number of confirmed cases in the USA changed quite significantly, or kind of exponentially from the 1st of March, right? So then we select the 1st March as the outbreak day in the USA. Okay, so after determining the outbreak dates, then we can divide the data, as I mentioned, into before the outbreak and after outbreak. So here the figure show you some of this the comparison of different kind of usage before and after the outbreak dates. So you can see that there are 4 figures here. So figure A, B, C, D. So A, B are the change, the CPU usage or change usage pattern before and after the outbreak, and then the B is the memory usage pattern, right? So you can see that for the CPU, you can see that there's a decrease in the CPU usage before after the outbreak. So there's more CPU usage before the outbreak and less after the outbreak. And you observe similar. We have the similar observation for the memory usage as well. And let's look also, the figure C. So figure C here is the distribution of Wi-Fi usage percentage, right? So the Wi-Fi usually we say that the Wi-Fi is commonly deployed indoor, right, and has limited coverage. So basically we can see that the Wi-Fi usage have increased up to the outbreak. So basically, you can say that the people spend more time indoor, after the outbreak, right? So you can see that the usage have quite significantly increased. And then also the figure D also show the network switch percentage, right? As we mentioned that the switch is basically the network switch from Wi-Fi to cellular and then to cellular or from cellular to Wi-Fi. And as that the network switch usually happens when the mobile user move from indoor to outdoor, or later from outdoor to indoor, right? Therefore, actually have kind of review some of the mobility intensity of the smartphone users to some extent. Okay. And we see that you can kind of say that the switch basically kind of implies some kind of user mobility, right? That basically before that you can see that the percentage of network switch is larger compared to after the outbreak, right? So you can see that people are kind of more stationary or less mobile after the outbreak. So it also makes sense that since people spend more time at home, like work from home, as we say, right? Okay, then so this is some preliminary result, and then we'd like to go into more details. So what we're trying to do is here that because of this kind of simple statistic, and so basically make generate this hypothesis that the outbreak of COVID-19 lead to a new usage spectrum of smartphone, right? Which not already appears on the data on the dates before the outbreak. So basically, our hypothesis is that the outbreak have create a new usage patterns. So this is our hypothesis, and then we would like to look more detail into data and to see whether this hypothesis is true or not. Okay. So to do this, we first define diurnal pattern. So basically, a diurnal pattern is an essential temporal pattern which showing how users' smartphone usage behavior over the time of the day. So basically, it's the patterns for one day. Okay, and it show you that for example, from the time 0, hour 0 to 24, like hour 24, and it show you the different usage of the throughout this time period, right? And we define the diurnal pattern of each day by averaging the usage data over the active users of day. So we have 452 users, right? And we average their usage for that date, and then we use this. We define this as the diurnal usage of that sensor. Okay. After doing this, we apply k-mean. So we set k equal to 2 to cluster the diurnal pattern across the entire 182 days. So from the November 1st, 2019 to the April 30, 2020, right? And next, we examine whether the clustering result can be distinguished by the outbreak day of COVID-19 or not. Okay, so this is the preliminary. And then we're showing the results. Right, so this slide show you the clustering results of the memory usage. So you can see that we have two clusters in this here because we apply k-mean and set k equal to 2. So we have two clusters. So I have cluster A and cluster B. Cluster A is in the blue color, and cluster B is in the orange color. And so these are two clusters, right? And since we just input the whole set of data and we didn't distinguish before or after, right? So we assume that this clustering is kind of is not biased because of resetting the date. So it's naturally divided into two clusters, and then we're trying to look at these two clusters and the users inside these two clusters. How they differ from before and after. Okay, so we can see here is that based on this figure, we can observe that figure B here, right? So this is figure B, and the figure B is showing the proportions of cluster A user and cluster B users before and after the after the outbreak. So you can see that before the outbreak, right, there's a lot of cluster A user here. And after outbreak, there's a lot of cluster B users, which are classified over there, right? And you pay attention to the figure A as well. You can see that the cluster user are the user which have, they have used a lot of memory. Sorry, it's not a lot of, but they have higher memory usage compared with the users in cluster B, right? Right. Of course, if you look at the shape, the shape is quite similar. So basically, there's day zero here. So basically, both of the it's not day zero times zero. Basically, up to the midnight, right? It's the midnight. So they have similar usage pattern. So at the midnight, it's low. The usage is low, and then it keep low until the morning, and they increase during the day and stay relatively high during the day and dropped in the evening as well. And it's also similar pattern for the cluster A. The main difference is that the cluster A have higher usage compared to cluster B. Okay, so here we can kind of conclude that the outbreak of coronavirus create a new typical diurnal pattern of memory usage and lead to a decrease in kind of smartphone engagement of users. Okay, so this slide shows you the plot for the CPU usage. So you can see again, there's cluster A and cluster B here. You saw again similar pattern about usage, and they follow quite similar shape. But the still the bull curve is above this the orange curve. Okay, so again, right? So there are these two clusters, and then we also look at the again the proportion of the cluster label. So we show you the before and also after again. So what we see here is that right, then there's more cluster B users concentrate after the COVID, and there's actually of course they also a bit more before. So basically that the relatively more of cluster B users before and after the outbreak in this in this case, right? So basically we can say that yes, the outbreak have changed the proportion of the smartphone usage, right? That the CPU usage, that there's slightly increase in the number of cluster B users over the after the outbreak, but there's not really kind of too significant change, right? So therefore, in this case, we say that the COVID actually only changed the proportion of existing pattern instead of leading to a new typical pattern of CPU usage. Okay, so then we continue with the Wi-Fi usage pattern, different from memory usage. Also, apart from the apart from the magnitude or value different, right? The same choice of the Wi-Fi usage cluster have the different changing chain. So you can see here that on this on figure A, there's the cluster A have kind of a deep a cliff-like drop down here, right? That you can see that cliff-like drop down, which indicate the user switch network type to several connections at that time, right? Nevertheless, the same choice of the cluster B have a higher percentage of Wi-Fi usage throughout the day, right? But it doesn't. It have some kind of drop here as well, but it's not as significant as what you can observe from the cluster A here, right? It's so it's so that in terms of Wi-Fi usage, right, the change of the observation that you can make is kind of more significant here in this case. Okay. So right, so we say the cluster B occupy the most proportions of the data up to the outbreak of the COVID-19, around 79%. So you can see from here. So the orange one is around 79%, right? But then before that, then the cluster A behavior is dominating. So it's most of them actually have this cluster A behavior. So basically you have this kind of pattern over here, right? So in this case, we can say the COVID-19 bring a new diurnal pattern of Wi-Fi usage and leading users to use more Wi-Fi connections throughout the day as well. So you know the normally the orange curve here. Okay. So then finally we look at the network switch. The network switch is, you can see from here that again we have two ports. The first is showing the pattern. As discussed, as we mentioned before, right, that the network switches can reflect the mobility intensity of smartphone user, right? So so you can see that the centroid of the cluster A, you have two peaks here, one peak here, another peak here. You look at the time, so the first peak is in the morning, and the second peak is in the evening. So basically, they are the peak hours or the rush hours that basically it says that the users basically have a lot of network switches during the rush hours. So basically, it is very clear that the user, for example, in the morning, they leave their house, they take the public transport or drive their car to work, right? And so during the period, they have a lot of switches of network switches. You know, if you move, then you can switch from one cellular tower to another cellular tower, right? So you can see that there's a lot of network switch behavior over here. And kind of during the day, when you stay in your office, then you have kind of more stable pattern of changes, right? But then we also notice that in cluster B, the orange line there, there's there's fewer network switches, right? So basically, there's not as much as the cluster A, and so it's suggesting that the user have less mobility on the date in that cluster, right? So and then in terms of the result in figure B. We can see that there's the pattern is a bit like so you can see that cluster B have kind of dominating in the of the data after the outbreak, but it still have a quite a large portion before the outbreak, right? So you can see that before the outbreak, maybe the cluster B usage behavior is almost like a 50% as well. So in this case, we say that the COVID-19 kind of have an impact or change the proportion of different network switch pattern, but it still does not trigger the kind of the appearance of a new pattern here. Okay. So our conclusion here is that the summary here is that the outbreak of COVID-19 it have profoundly affect the diurnal pattern of smartphone usage behavior, and then so it kind of support our hypothesis, right? And then the next we trying to look at the research questions that we mentioned, that whether we can use the diurnal sequence of smartphone usage to infer the outbreak stage of the coronavirus. Okay, so first we have to define what means the outbreak stages, right? So we basically in our study we define that 3 outbreak stages. Stage 1, basically the period from February 1st to March 1st, 2020, which are the early stage of COVID-19. You can see from here, there's only a few cases up here. And then stage 2 from March 1st to April 1st, the daily confirmed case increased dramatically. And then stage 3, basically from April 1st, the increasing trend of COVID cases is kind of more stable after that. So we would like to see whether we can detect the with the input of 1 day, whether we can detect whether it's the days belong to any of these stages. Okay. So what we're showing here is that let me switch a little bit. Okay, so let's look at these figures. So so before we really doing the output detection, we need we need to first clarify the effect of the diagnosis delay. So basically, because when a person, a user got infected, right, that the you will have to go through the test, right, and then identify or confirm that this person is really infected. So this real infected until the date that is confirmed to be infected, they have some certain delays, right? So we say that due to the diagnosis delay, the outbreak situation cannot be immediately expressed by the daily case of coronavirus, right? So I want to first explore that after how many days the reflection of the smartphone usage will emerge in the COVID-19 statistic. So if we look at the figures, right, we have used we introduced 3 different kind of classifier and to do the prediction, and we saw the both the micro F1 score and macro F1 score here with all the 3 classifier. Okay. So so the dates here are the dates that that we with the lagging of the delay, right? So we can assume that we can use the data with the 1 day delay, 2 day delay, 3 day delay, 4 day delay, and then we make the inference of the outbreak stages, and we compare the accuracy, right? The F1 score over here. So what we saw here is that you have the 3 classifier is the linear regression here, the SVM, support vector machine, and also the more advanced SG boost. So what we see is that for the linear regression classifier, the performance here have multiple pit, right? That you have multiple pit here. Then the reason is because the linear regression classifier is a linear model, which is difficult to capture the correlation between the smartphone usage feature and the COVID outbreak stages. Alternatively, the performance of SVM and the SG boost, actually they are better compared with the linear regression. And we can see that the performance become the best, or better, at least when the delay days increase from 0 to 3, and then from here, right? So the delay is kind of slightly, the accuracy slightly increased until the 3-day delay, and then it got dropped again. So it tells us that that in this case that that the daily case statistics are delayed by 2 to 3 days. Okay. So then after the kind of more preliminary results, we're going to look more detail into the how actually the performance actually whether the performance can be improved with the more advanced algorithm, right? So here we propose an embedding a model for the smartphone usage behavior utilize different smartphone usage features fully. So the features here we mean the CPU, the memory, the Wi-Fi usage, and also the network switch. So those are the inputs into the system, and then we compare. We use this sequence to sequence model to extract some kind of kind of hidden informations rather than only these raw features, and then we so basically this is embedded method, right? So and then we compare the performance with only using the raw features. So basically only the 4 features, and also the combination of the raw features and also the embedding, the future extract from the embedding as well. So you can see that in general, the green one are the embedding with the raw data as well, the combination, and you can see that in generally it perform better, right? The embedding algorithm, the more advanced algorithm perform better. But no, actually they are both using SG books, but they just the orange one have only the raw feature, and the green one which have both the raw feature and the embedding feature. So you can see that the green one actually in general perform better. And again, the best performance on the with the 2 days delay in the system. So and the accuracy is almost like around 90%, right? In this case. So we can notice that let's say that we know with the embedding, right, that you can reach 0.9 for both macro and F1 and micro F1, and have around 25% improvement compared to only using the raw features. Okay, some takeaway message here. So before I go into the next topic, so our finding indicate that the user smartphone usage behavior in this change across the outbreak of COVID-19. However, the coronavirus have kind of different effect on different kind of usage behavior regarding the changing trend and the diurnal patterns. Also, we demonstrate that the potential of using smartphone usage data to infer the future outbreak stages, which can achieve over 0.9 for both macro F1 and micro F1. And our finding actually provide a novel application of smartphone usage data for COVID-19 study. We hope we can explore more value for fighting against the pandemic in the future world. So we are still, as I mentioned before, that this is kind of more preliminary work, but we are still, as we know that the pandemic is still going on, and we are still collecting the data and continue working on these topics. Okay, then. Let me also move quickly to a next topic. I'm going to present the health framework. Basically, is sensing 5 grand individual health condition with the mobility data. And this work is already accepted to the ACM IMWOOD, and is going to be published next month. Right. Okay. So sensing people's health condition by using ubiquitous data is a promising topic in recent years. So we can see that recent year there are more and more publications in this area. Specifically, there are 3 main applications that we can in this domain with ubiquitous computing and health. So the first one is that we can use wearable device to sense an individual's health better and offer more personalized service. So this is personalized monitoring and personalized service, right? Then we also can help hospital to construct a more effective and more accurate patient classification system. And the third one is to help the government to better schedule the resource in the city, such as planning of the green space and medical resources. So this is kind of 3 typical applications that we observed that from the recent related work. Right? However, the current approach have some limitations. And many of the studies require manual interactions between the patient and the care provider. The second issue is that the wearable devices are not ubiquitous enough yet at the moment, right? That some patients wear wearable device, but it's still, not very common yet. The third one is hard to collect large scale ubiquitous data, especially people worry about the the privacy of the data apps. So these are some of the limitations of the current work. So for us, right, that we are trying to take a more kind of non-intrusive approach, or basically, or we say that we want to look at the problem from a different angle in this study. That instead of using wearable device, ubiquitous device, whether we can make some kind of health condition inference by just using the mobility data from the telco operator, right? And how much information we can infer from just these mobility traces. And so basically, through the previous study, we have found that some work have proven that the correlation between physical activity and then the people's health. Natural and scientific extension would be to see whether the individual mobility traces I mentioned can be leveraged to sense some more fine-grained health condition, right? Then, so this is the purpose of this health work framework. So the health works framework leverage heterogeneous data, including the mobility traces and also demographic information, and then to sense kind of both cause and fine-grained health condition, while preserving some decent interpretability. So basically, besides the sensing, and we also trying to give some interpretation about these data, as well, from the algorithm. So in our study, we collect real-world mobility traces along with the user demographical and the medical information. So basically, this is a study with a collaboration with a telco in Beijing, in China, and the patients are enrolled in the study and themselves. So they are volunteers for the study, and we got the agreement to collect their data from to collect data from the telco, and also and for their also demographic and medical data, right? We also combine the raw mobility record with the point of interest data to enrich the sentiment of the trajectory. Okay, so here is the information about data. So as mentioned, the data was collected in Beijing in the period of 1st July to 31st of August 2017. So it's 2 months with the record of around almost 1 million record, and I have 747 users. And the location covers basically the POI location have covered 15,000. Okay, so these are the demographic of the users. They contain the genders, age, education, and income level. So basically, we can see that in our study, there's more female. Around 72% of the users are female, and the age the age group is kind of quite evenly distributed, but less old people. Right, less old people, only 7% of the users are above 60, and the education background. So so some of them are quite highly educated. So around 26% of them have been to the undergraduate, and then 20% even have postgraduate educations. And the income has ranged from a relative high. Actually, we have 60% of them are with a high income level, and then around 10% of very high income level. Okay. Okay, so to initially explore the correlation between mobility pattern and disease category, we designed 3 basic and classical metrics to represent the mobility patterns and to showcase their distribution among the disease category. Okay, first of all, we compute the mobility entropy for each user. So the mobility entropy is here. So in the figure A, you can see that this. Okay, then figure B shows the straight line distance. Basically, is the sum of distance traveled by an individual per day, and then figure C shows you the maximum distance from home. So basically, is we infer the home location of the users, and then we measure the maximum distance traveled by this user from the home for each day. Okay. So the 3 figures showcase the difference of the mobility metrics lying in different disease category. So you can see that the S-axis are the disease category. So basically, have the healthy one, the dental, the mental birth, endocrinally, and etc. And they have the cardiology here as well. So we can see that. Let's just look at this entropy case, right? That where the healthy group and the dental group display a more active mobility pattern. So basically, the higher the entropy means that the higher the mobility pattern, right? The more active the mobility, and the shorter the distance, right? Means that the shorter distance means that less less mobile or more stationary, right? So you can see that the health one and the dental one, they have higher mobility in these in all these 3 cases. And while the mental birth and orthopedics group show more kind of inactive mobility pattern, right? So then the mental here, you can see the mental is a little bit later, and the birth as well, right? We know that usually pregnant, you are pregnant, you probably don't move so much in this case. Okay, so these are kind of agree with our intuitive intuition and common knowledge. Okay, then the next we formally define our utilize data and problem. So our target is to predict the potential health risk for each users based on the mobility metrics automatically generated by deterministic finite automaton. I will going to show you these automaton in the next slide. But then some of the definition here that we'd like to show you first. So first we want to define the urban mobility record, the UMR. So basically, the UMR, the input to this automaton, right? What inside this UMR is here. We say that UMR is quaternion. So basically have 4 parameters inside each one. So we denote the user U. So U is the user's visit or location L. At time T is here, and stay at the location for duration of D. So you have these 4 parameters over there. So and here where L denote a unique area with the graphical coordinates. So basically have the longitude and latitude, and also the boundary in the urban space. So these are the record we call the urban mobility record, and which are, you see that is going to be the input to the automaton. Okay. Then given the mobility trait record of the users with the associated POI distribution data, so we as I mentioned, our goal is to predict the potential health risks for each users based on the mobility matrix. Okay. Okay, so before I go in detail about the algorithm and the methods, so I would like to first cover some of these challenges over here, right? Then there are three main challenges to achieve our goal. First is how to model the complicated relationship between the users and location, right? So, we have the users and we have the location, and which include, as I mentioned, include the location itself with the longitude, latitude, and also some of the POI nature. Right? So how can we model the complicated relationship between the users and the location? And the second is how can we capture the health signal, right? That we have this data, but how we capture better the signal, and then how to balance between the accuracy and interpretability, right? So maybe algorithm, we want the algorithm to be accurate, but also we want to be able to interpret the result. So these are the challenges that we have in our study. Okay, so then the method, as I mentioned about this automaton here. So here what you see in this figure is kind of deterministic finite automaton, and you can see that it is show you our form of the model, or our model, right? Health work using the automaton. So each circle represents a state, and each arrow symbolizes a transition, right? So you have the state here, and then you have the transition. Okay. And the initial input of the DFA is the sequence of raw mobility record together with the POI distribution vector. So basically, the input are the UMR, which consisting of the mobility record and also the POI distribution vector. And then the final output is the mobility matrix for the users, right? The demographics are both external and internally aggregated into the complete framework. So basically, the UMR here, you also contain this information, demographical information, and also actually input to the final stage as well, the matrix, the final matrix over here. Okay, so these are the operations. Some of this we have defined kind of 5 different kind of operation or legal operations, and within each operation there are different transitions. So for example, if you look going back, right? So we have the filter here, and then we have the S, right? Select over here, and then we have aggregate operation over here, and you can see if you want to look at more details into the transition, right? So for example, the filter, we do this kind of transition. You will keep, for example, you keep record of weekday or weekend, keep record during the daytime or nighttime, keep record around home or workplace, right? And then select, we'll do select the coordinates of the location, select the count of surrounding POI, select the variety of function, right? And then, for example, the aggregate, aggregate the radius of gyrations, the average uncorrected entropy over all days. So, it would do all these kind of operations here. So this is how this health work framework works. Okay. So then we use the features generated by the DAF to predict the specific health risks of the users, right? As we have the ground truth of the user, what kind of disease they have from their medical record. So we have the ground truth, and we predict using these features, and then compare with the ground truth. And this show you some of these baseline. For example, you have this random guess, so this is the random one, so you just randomly guess. Then we have some more, basic algorithm like the multi-layer perceptron, the LSTM, also the algorithm of only using kind of demographic information and then manually select some of the features, and then we have this health work over here that with a different kind of valuation, right? That that the health work with only the mobility data, the health work with both the mobility record and the demographic information, and then also the POI information as well. And finally, you have this overall, right? The overall information that we combine all the features. Okay, and we can see that that with all these features, right? That we can observe that the model can actually achieve better performance compared with the other all the other baselines. So have kind of 22 or 23% improvement compared to the others, to the best baseline, and also the here also around 12% improvement. Okay, so also evaluates how the models perform varies across user group with a different disease category and demographics. So on the left-hand side is the confusion matrix, which is that some category are easy to pick out, where some disease category are confusing similarly to each other, right? So you have the confusion matrix over here. And then on the right-hand side, we also showing how the model's performance will be affected by the demographics. So from figure A, we can see that the female group have a slightly higher F1 score than the male group. And then we also look at the ages, right? Which showing on the figure B. Sorry for not labeling them. And we can see that the F1 score of disease category prediction decrease as the age increase, right? And this is probably because the older people tend to get into more disease as well as become less physical active, right? So then actually result in less information to distinguish different health conditions. And then we also look at the performance across different income groups, which you can see here is show you from the lowest income to the highest income, and we can see that the performance consistent increase as the income level increase. And as we say that the one possible reason is that people with a higher income level might lead a life with a higher standard and pay more attention to their well-being. A similar finding you also saw in the figure D, where the postgraduate group shows higher performance than those with a lower education level, and this quite similar reason as the income level as well. That the possible reason is that people with a higher education level might lead to a higher income level, which also kind of we say improve their life quality. Then this figure, right? There is this slide show you the just to show the interpretability of our algorithm. So here we are using this. We use the shape value, which are based on game theory, to measure the importance of the features on the prediction. And here we show the top 5 features for the classification model. So you can see from here that each dot in the graph corresponding to one user, right? And its color denote the value of the feature. So you can see also that the red color have higher value and the blue color have lower value. Okay, and then with the horizontal position here, denote the sharp value of the feature linked with the outcome, right? So you can see that is you have a higher, this one is 1 and the left is -1. So the higher value basically tell you that the feature have higher link with the outcome of the Peterson. Okay, so so we saw here two cases. One is the healthy situation, and another is the cardiology. And I will spend more time talk about the healthy case. So we can see from here the healthy case one is on the figure on the top sub figure. So we can see that the most prominent factors in recognizing healthy people are the total entropy and the daily average of entropy of visit location around the workplace during working hours. Okay, so here the random entropy, and then also right, this work trajectory here as well. And the larger entropy basically contribute to a higher probability of being healthy, which lead to the understanding that those who are able to visit various locations around the workplace tend to be physically more active, and consequently more healthy, right? Because you'll be able to move to more different places, around your office place. So you have probably you have less mobility problem, right? And okay, and another influential feature is the average daily average of company POI visit on the weekday away from the workplace, right? The POI here. So a high value of which indicate a higher tendency of being unhealthy, right? So the red ones you can see here, right? That the means that they on this side, right? So the reason there is that the visit to company outside the workplace are usually due to business, right? So a large number of such visits kind of indicate a higher probability of overworking and even over fatigue, which also lead to kind of healthy health issues over there as well. Okay. So I will leave the. I'm not going to spend too much time on the cardiology case because due to the time limit. But you can try to look at the figures yourself if you are interested. So then the next slide we saw in the one case study. This case study is about this endocrinology case. So you can see from here that this figure shows the reasoning procedure with some kind of local explanations here about the diagnosis of the disease. And we can see here we have the two cases OVR, which stand for one versus rest. So basically one disease compared with all the others together. And then we also have the OVO case. So basically it's one disease compared to one of the other disease. So, just kind of comparisons over there, right? So the red, you see that the red arrow here, which indicates the feature effect that drive the SG books outcome higher. Okay, so yeah, I mentioned that we use SG books as the algorithm, as the machine learning algorithm over here. So the red color, kind of, indicate the feature effect for drive these SG boost outcome higher, and while the blue color, which are here, which are the arrow will show the feature effect that drive the result lower. Okay, so you have the effect over here to solve, right? Okay. So the OVR classification result displays the recent right. So the OVR is here on the top, right? So you can see that display the reason for choosing endocrinology as having frequent visit to restaurant during working hour and have so it's here, this matrix here. And also the having a low daily average of mobility entropy during working hours, right? Okay, which are the factors which pushing the value to be high. Okay, and also look at the result of OVO classification. Basically, it explained against predicting the, for example, in this one, the endocrinology against birth, right? That in this case, so it show you the prediction, the birth department by highlighting the notable frequent visit to restaurant, some more frequent visit to restaurant, and the age. Here you look at the age here. So 56, which is unlikely to give birth, and against the prediction as healthy by for the healthy here by frequent visit to a restaurant and scarce visit to sport-related locations. Okay, so some POI here that the right over here, right, and then so this a random entropy here, which drive this value the prediction lower as well in this case. Okay, so basically we are using this reasoning process here. So we predict with the prediction result to be endocrinology, and then we have the reason explaining about why this. So you have this value over here, right? Then why not birth? So basically you also give you the matrix, which give you the value, and based on this value you do the reasoning. Okay. So to conclude the results, combine consistent result with reasonable and comprehensive explanation. So in case successful attempt at department suggestion with the tailored reasoning as reference. Okay, so we have these different kind of reasons, and to support the these predictions. So this actually give a very nice image of visual interpretation about this prediction and the result. Okay. So to summarize this part, right? So here's the summary. We develop a health work framework that combines point of interest data with the raw trajectory data to generate a large number of physical and semantic mobility matrix. And from our study, we can see that the health work can achieve like 42% in the micro, 40% in the micro F1 and 31.63% in the macro F1 for the ACAS disease category prediction, which outperformed the best baseline by 25.84% in the micro F1 and almost 32% in the macro F1 case. Okay, so I think I would conclude my talk here. So if you have any questions, please don't hesitate.
Hello, my name is Stavros Miloulis, and I'm going to present you the paper Evaluating Memory and Cognition via a Wearable EEG System, a Preliminary Study. Our initial motivation for the current research was to evaluate a simplified EEG framework for studying cognitive functions related to aging and dementia. The individual goals were to investigate the applicability of single-channel wearable EEG in assessing cognitive training effects, as well as to examine these effects of cognitive training on face recognition functions related to controlled and automatic processing. For this purpose, we firstly acquired behavioral and EEG data from healthy volunteers during cognitive task performance. These data were pre-processed for removing noisy components before extracting our metrics and conducting statistical analysis. Key results showed a significant EEG contribution in explaining behavioral outcomes, even with a single-channel recording device. In addition, during the cognitive training sessions, we were able to observe differences between two types of cognitive processing, namely controlled and automatic processing. For the purposes of this study, cognitive training can be defined as a non-pharmacological intervention aiming to maintain, enhance, or even restore cognitive functionality. Within the scope, applications may vary from basic exercise of cognitive skills, for example, a simple crossword, to advanced protocols for dealing with the effects of cognitive disorders. Regarding the latter cases, the ambition of cognitive training is to induce neuroplasticity in an attempt to bypass the disorder effects and help the brain adapt by seeking alternative neural pathways. In this scope, techniques such as electroencephalography, EEG, provide the means for assessing underlying physiological activity, reflecting cognitive processes constituting a measurable manifestation. The availability of multi-channel workstations grant ample capabilities to researchers regarding data analysis. However, there still exists a place for simple setups. More specifically, in cases where portability and usability are of primary concern, or when dealing with elderly or cognitively impaired users, the simpler the better. Therefore, we believe that such paradigms require light and user-friendly setups that cause minimum discomfort to the user. Accordingly, our framework employs a wearable dry EEG device with an FP1 sensor and a reference sensor. This device is combined with behavioral metrics for performing cognitive evaluation of participants as well as cognitive training on face name recognition skills. Our cognitive training protocol is based on dual process theory, which highlights the distinction between controlled and automatic processing. More specifically, controlled processing occurs unconsciously and is guided by stimulus, while automatic processes are conscious and require more cognitive resources. Based on these principles, the former type remains relatively intact by the effects of age and disorders, while the latter is affected in the early stages. This distinction is the key to our cognitive training protocol. The implemented experiment includes the recruitment of 6 healthy adults who were divided into 2 groups, training group and control group. As depicted in the figure, both groups underwent 2 evaluation stages whilst EEG data were recorded. Although, while the control group did not perform any cognitive tasks between the 2 stages, the training group completed a 4-day training protocol. The pre-training and post-training evaluation stages included three cognitive tasks. Firstly, we employed a phase name memory test consisting of three phases. Initially, participants were presented with phase name combinations which they were asked to recognize in a series of yes or no tasks. If participants recognized a phase as part of the initial list, they also then had to provide a name. This process was completed both shortly after the study phase and after a time delay of approximately 20 minutes in an attempt to assess short-term and long-term memory. The second task engaged verbal memory. Instead of phases, word pairs were presented, and participants were then asked to recall the second word of each pair when presented with the first one. In addition, after a time delay of 20 minutes, we presented a series of word pairs and the participants had to recognize those that belonged to the original list they had learned. Finally, working memory was assessed via the end-back task, where an individual is presented with a sequence of digits and is required to recognize if the current digit appeared n positions earlier. In that way, participants must always remember the last n digits. Therefore, the more digits they have to memorize, the higher the task difficulty. We implemented for this study three n values, namely 2, 3, and 4. 2 back, 3 back, 4 back. It should be noted that the first task, phase name memory, is the primary one, while the other two investigate whether cognitive training on phases can affect additional cognitive functions such as verbal and working memory. As mentioned earlier, our training protocol is based on separating automatic and controlled processes. For this reason, we opted for repetition lag training. This method is much like a simple face recognition task, since participants study a list of face name pairs and they later have to recognize these faces among other unknown faces. However, these unknown faces may be presented more than once during the experiment. For instance, the repetition phase in the second image is presented twice. The second presentation triggers a familiarity effect on the individual who has seen this face before, though not as part of the original list. Therefore, the participant has to recall learning context and remember if the face was presented during the recognition tasks or during the study phase. In that way, repetition lag training is believed to strengthen controlled processing skills. In addition, the interval between two consecutive presentations of a repetition item, either a face or a word in the first image, is called the lag interval and represents the difficulty level of the task. Upon completion of data acquisition, after the participants perform training and all the cognitive tasks, we implemented the pipeline shown in this figure on the EEG data. Firstly, we applied bandpass filtering and linear detrending for basic denoising. Afterwards, since the nature of our data limits the methods that may be applied, we use the specialized methods for single channel recordings. Based on this process, the channel is separated in components called intrinsic mode functions, representing periodic oscillations within the original signal. Then, independent component analysis is applied on these functions in order to identify four new components. Based on high amplitude and the low frequency content, we removed the component representing background EEG noise, and finally we reconstructed the initial signal. This method is called EMG-ICA, meaning empirical mode decomposition with independent component analysis. During the next step, we identified the distinct epochs corresponding to our trials. For these epochs, we estimated EEG synchronization by calculating induced band power for all EEG bands individually. Then, using the power of the reference interval as our baseline, we calculated the percentage change in band power. Positive changes corresponded to event-related synchronization, while negative changes corresponded to desynchronization. These phenomena, ERS and ERG, represent collective increases or decreases in neuronal activity at a given frequency band. Finally, we extracted statistical metrics from EEG waveforms, as well as behavioral measures describing task performance by the participants. In order to investigate training effects induced by a protocol, we compared pre-training and post-training results for the training and the control group. Ideally, we expected to find that the control group that did not follow a protocol did not present any differences between the two cognitive evaluation stages. For this reason, we applied a series of t-tests on each feature at a significance level of 5%. This table summarizes the key results of statistical analysis for the two groups. As we can see, the control group indeed presents almost no differences, while many statistically significant differences were detected for the training group, including both behavioral and EEG features. Inspecting the results, we can see an unexpected decrease in behavioral metrics for the training group regarding performance in the face name memory test. This fact was partly attributed to the reports we received by the participants on fatigue due to days of continuous training. However, another cause may be the response bias that was also reported due to practicing using the repetition lag procedure. Specifically, participants admitted that they expected a repetition phase rather than a study phase, being more willing to refuse to recognize a study phase than to falsely recognize a repetition. In that way, performance anxiety during post-training often led them into altering their intended responses, resulting to more errors compared to the pre-training evaluation. Such activity, on the other hand, may indicate improved processing despite the behavioral outcomes. In addition, we found indications of an increased workload post-training as well as enhanced processing for the training group, indicating the overall higher engagement of the training group with the tasks. Finally, no indication was provided on whether the improvements in end-back performance should be attributed to transfer effects due to the training process or mere task experience due to repetition. Finally, some comments regarding our experiment. With regard to employment of EEG recordings, we concluded that the incorporation of single-channel measures can indeed assist in the interpretation and validation of behavioral results. Moreover, a single-channel processing pipeline is able to give prominence to statistically significant results, while synchronization metrics are a viable alternative to ERPs in minimal setups. As for our training protocol, we found clear effects on the participants regarding both processing skills and fatigue, while also observed the clear distinction between automatic and controlled processing, identifying the related time windows during responses. In utilizing the results and expanding our research, we have some ideas on every aspect of our study. Regarding dual process theory and repetition-like training, we aim to further investigate the underlying mechanisms using EEG to distinguish and compare brain activity during familiarity and recollection, namely recognition processes. Moreover, we aim to recruit more participants for increasing statistical power and modify our protocol to extract more EEG epochs for data analysis. Finally, we will compare multi-channel analysis results based on advanced and widely used techniques such as brain connectivity and ERP analysis with single-channel outcomes in order to determine the extent at which we may exploit a single-channel framework. What can we learn from a single channel compared to what can we get from the full framework with a large number of channels? Through this process, our ambition is to establish a reliable training protocol that utilizes EEG activity in order to induce significant effects on cognitive functions, both on healthy people and in cases of cognitive disorders. Thank you very much.
Welcome to my presentation. My name is Florian Diemer and I'm going to talk about preprocessing pipelines for electroencephalography in a mobile context. The presentation is structured as follows. First, I'm giving you a basic introduction to tinnitus and mobile health. Then I'm going to introduce the Tinnitus Sense app, which is the app we created to gain additional information about tinnitus. In the next section, I'm talking about EEG preprocessing, including how we defined the pipelines and also how we implemented them. And subsequently, I'm showing you the evaluation results before the presentation is concluded by a summary and a recap. The following slides will provide you a short introduction to tinnitus, mobile health, and also the Tinnitus Sense app. Tinnitus is a complex and heterogeneous disorder which is associated with causing the perception of a continuous clicking, ringing or buzzing sound in the ear in absence of any external sound source. Approximately 15% of the world's population suffer from tinnitus, out of which 2% experience a substantial decrease in quality of life. People who perceive tinnitus have defined its properties to be like singletone, multitone, noise-like, or having no tonal quality at all. It can be constant, pulsating, or intermittent, and can also occur instantaneously or progress over time. So as you can see, the tinnitus perception differs from patient to patient. In addition to general health complications, some evidence suggests that tinnitus might also be responsible for provoking and getting influenced by other psychological disorders like fatigue, stress, anxiety, depression, amnesia, and also insomnia. It is also established that tinnitus affects the common as well as the social lifestyles of its sufferers. As tinnitus has that many characteristics, it is important to collect as much data as possible to allow a good therapy selection for each individual patient. Among variety of smartphone-based solutions for tinnitus management, smart mobile crowd sensing can be a viable solution in understanding tinnitus. Smart mobile crowd sensing mainly comes in two flavors. First, the participatory sensing, which is where the user voluntarily participates by contributing some information, like for example filling out a questionnaire or something like that. And second, the opportunistic sensing, where the data is automatically sensed, collected and shared without requiring the user to intervene. This is achieved by either using the internal sensors, which are built into the smartphone, or also by coupling an external auxiliary sensor device. Smart mobile sensing can be applied on different levels, like individual sensing to monitor movement and activity, group sensing to measure quality of air or sound pollution, and also urban scale to track spread of a disease, like for example the current COVID pandemic. And also smart mobile crowd sensing solutions can be applied with a specific focus on people or on the environment. Both is also possible. Nevertheless, smartphone apps are also interesting, as smartphones provide an application ecosystem which is extendable to program and include new apps targeting different health problems at almost no costs, which is also the case for the tinnitus disease. Herein, to better understand the phantom phenomenon of tinnitus, smartphone-based ecological momentary assessments, short EMA methods, can be utilized to capture the variations of tinnitus perception, and they can be linked to the current surrounding using the environmental conditions as well as the electroencephalographic conditions of the patient. So as you can see here, the individual tinnitus profiles along with the existing standard tinnitus questionnaires, like for example the tinnitus handicap inventory, the tinnitus functional index, as well as the mini tinnitus questionnaires, can also be beneficial for tinnitus related assessments. On the other side, for monitoring the environment, the embedded sensors of the smartphone, like for example the motion sensors, the environmental sensors and also the position sensors, can be employed. For recording electroencephalographic data, a mobile and ambulatory EEG data system can be highly beneficial. Let's have a look at the technical architecture of the application. We run our application on a standard Android device, as you can see here, and the components of the application are the tinnitus profile and the questionnaires, which were already discussed previously. This includes the THI, the TFI and also the mini TQ. And then we have a sensor service, which allows recording the embedded sensors, like for example the light sensor, temperature sensor or pressure sensor. And the sensor data can also be visualized directly on the graphical user interface to allow the user to see what data is currently recorded from the sensors. In addition, our application also allows to directly connect to an EEG amplifier, as you can see here. The EEG amplifier is connected via Bluetooth to the application, and once we receive new data, the data is sent to the EEG data parser module, which parses the data and sends it to the EEG preprocessing pipeline, which I'm going to talk about later during this presentation. As you can see, we implemented a high-pass filter, bandstop filter, and also a re-referencing filter. But I'm going to introduce those filters later during this presentation. After the data has been pre-processed, the EEG data can also be visualized on the graphical user interface. We visualize the data using our own diagram for each EEG channel, and also we make sure that only the data which is currently visible to the user is updated to conserve resources. Before I'm going to talk about the pre-processing, I want to give you an idea on how the app looks, what possibilities exist to configure the application, and how the user can interact with the application. Here you can see a screenshot of the application's home screen. By clicking on the Sensors button, you can access the embedded sensors and switch on or switch off individual sensors. The survey is accessed by this button. Then the user can fill in a survey and submit the survey. And we also have a user profile which stores general information about the patient's tinnitus status. Using this button you can connect to external sensors, like for example an external EEG device. Once a connection to a EEG device is established, a workspace can be created. The workspace can have a name, recording mode can be specified, sampling rate, and also the enabled channels. There can exist multiple workspaces, so you can quickly switch between workspaces and they can also be modified. By clicking on a workspace, the visualization screen shows up. For starting an EEG recording sessions, there exist multiple options. For example, the data can be recorded to the database. Then the data can only be monitored, which means it is only visualized on the screen but not stored in a database. And it's also possible to request a test signal from the EEG device. On this screenshot you can see the test signal, and on this screenshot we use some sample data. Before going into EEG data preprocessing, it is important to know why preprocessing is required. Since the recording session does not take place in a controlled setting, like a laboratory, but in a real-world scenario using the mobile application, noise and subject-generated artifacts can be introduced to the data. Hence, the data must be cleaned, filtered, and the artifacts must be removed before the recorded EEG data can be used for additional applications. Usually, this step is carried out by executing the preprocessing steps on a computer, which is either directly connected to the EEG device, or the data is transmitted to the computer after the recording session has finished. This of course limits the real-time analysis with freedom of movement in a real-world scenario. To solve those issues, we implemented a preprocessing pipeline as standard Android app and showed that modern smartphones are capable of running the pipeline without consuming too much resources. This also allows directly using the preprocessed data for further applications. As no standard preprocessing pipeline exists, we compared 3 common pipelines, which are also shown in this table, and selected the most common filters for our pipeline. Please note, the table only includes the filters we selected, but the 3 compared pipelines also include additional filters which we did not implement. However, you can find the full version of the table in our paper. So let's have a look at the table. In the first row we can see some filters which are used for signal filtering. The app approach uses the third order Butterworth filter, and the Makoto approach uses a high pass filter. Consequently, we decided to also use a third order Butterworth high pass filter. And in order to remove the power line interferences, the other approaches uses a clean line filter. However, we decided to use a bandstop filter, which has some drawbacks because it causes signal distortion. Nevertheless, we decided to use this filter because the clean line filter consumes a lot of resources which are usually not available on a mobile device. However, we are currently working on an optimized version of the clean line filter, so the bandstop filter can be replaced in future. And in order to detect bad channels, the Prep and the app approach also have some mechanisms, and we basically took the mechanism from the Prep approach and modified it for our scenario. Regarding the implementation, I just want to give you some basic information. The Android app is implemented in Java, and the preprocessing module provides an filter interface, which simply includes a filter method. The interface is used by the abstract class pipeline, which provides additional methods which are required for all types of pipelines. And the incoming EEG data is basically stored in a circular buffer. The concrete implementations of the filters all extend the pipeline class, so they can all use the common methods, and it is simple to add new filters or replace filters. Those app screenshots show how the pipelines can be configured in the application. So it is possible to enable and disable individual filters, and also some parameters can be specified, like for example the order, the sample rate, the cutoff frequency, and so on. So the filters can be combined, and it's also possible to only use some or none of the filters. We run our pipeline on sample data, and on this slide the results are shown. The red line stands for the raw data and the blue line for the preprocessed data. As you can see, for the high-pass filter, the signal did not change much. But for the bandstop filter, we can see that the signal is more smooth. And in the case of the re-referencer, we see some up and down shifts by keeping the amplitude the same. And when applying the whole pipeline, you see the most difference between the raw and the pre-processed signal. Similar to our previous evaluation strategy to objectively evaluate the developed app, 2 observational parameters were identified. Once again, the performance and the battery parameters will provide insight into the capability of current smartphones to pre-process EEG data directly on the phone. The developed app was evaluated on the Huawei P20 Lite smartphone, and the Android Studio profiler was used to record the evaluation data. 5 different runs with continuous EEG data sampling with the EEG amplifier configuration and filter settings as shown in the table were performed. Those charts depict the performance results of the Tinnitus Sense app with the pre-processing pipeline extension. For the performance results, we can see that the Huawei P20 Lite smartphone was capable of pre-processing EEG data with limited resource consumption for individual filters as well as for the entire pipeline. On this slide, the results of the overall battery runtime of the EEG preprocessing pipeline extension for individual filters as well as for the entire pipeline are shown. We can see that continuously preprocessing EEG data with all filters enabled on the Huawei P20 Lite smartphone with 3000 mAh battery capacity was able to run for about 4 hours, which should be sufficient as most EEG data recording sessions only last for 40 minutes. The proposed extension of the Tinnitus Sense app will allow real-time analysis of EEG data using smartphones. This will significantly reduce the added EEG analysis steps, since usually these steps involve manual steps of running different software programs or scripts. And in addition, this extension will also eliminate the need of third-party software packages for rudimentary preprocessing of EEG data. The app also contributes by assisting researchers in designing and gathering EEG data for large-scale longitudinal studies. For example, to investigate oscillatory brain activity of tinnitus patients in a longitudinal design by investigating patients that have moments with high and low tinnitus intensity. The developed app with preprocessing pipeline is a major step towards development of automated neurofeedback systems using smartphones. Here is a brief summary of what I talked about today. I started with a short introduction of tinnitus, mobile crowd sensing, and also ecological momentary assessment. Then I introduced the Tinnitus Sense app architecture and also the supported features. Before I started to talk about EEG preprocessing, why EEG preprocessing is required, how the pipelines were selected, and also the implementation of the EEG preprocessing pipeline. And I also gave a short example of preprocessing EEG data. Finally, I discussed our evaluation results, including the performance and also the battery consumption. Please note that this work was supported by the European School of Interdisciplinary Tinnitus Research. For additional information about the project, please visit their website. The link is shown here below. Thank you very much for attending the presentation. I hope it was an interesting experience for all of you, and if you have any questions, please feel free to ask them.
Good morning to all the MobiHealth participants, and thanks to the organizing committee. I am Angelo Basteris, and I'm an assistant professor at SDU, University of Southern Denmark. And I'm going to present you the work done by Charlotte Gesco-Thornberg and Frederick Birkolm-Leff as part of their bachelor project with supervision from me and my manager, Professor Uffe Koch-Will. Our work focuses on neck pain, which is among the highest causes of disability worldwide. And about 300 million people experience neck pain at least once in a year. So that is approximately 1 out of 25 people. It is the fourth cause of disability. Of course, like other conditions, there are several classifications for neck pain. Mainly, one first distinction can be made between acute episodes or chronic, which is typically referred as more than 3 months of recurrent neck pain. Other classifications can be of specific or non-specific, such as, so when a cause is known, it's a specific neck pain, non-specific or idiopathic, where it's an unknown reason. Of course, for instance, one cause for neck pain that we mostly could be familiar with is whiplash, which is often resulting from motor vehicle accidents. Now, regardless of its origin, neck pain can be associated to a loss of proprioception. And proprioception, a term that perhaps not all the audience is familiar with, is the sense of our own body. So in general, proprioception, regardless of the body part involved, is very important to coordinate our movement. In the case of the neck proprioception is of course a ground stone for maintaining balance, because the afferent signal from the neck proprioceptor is used by the vestibular system to maintain balance as we do while standing and walking. So of course the loss of neck proprioception can be, as we said, a leading cause of disability. Now, one way that it's traditionally used to evaluate neck proprioception is to mount a laser pointer, like here, on top of the head of a person, asking the person to face a target, and the person is usually blindfolded or his or her eyes are closed. And the therapist instructs the person to turn the head left, right, up or down. That will be neck flexion, extension and flexion respectively. And then to match back, trying to go back to the center of the target. And the distance between the final position and the center of the target is an indication of how accurate the person is at recognizing this position, and thus it's a measure of their proprioception. And this is what physiotherapists worldwide do regularly in clinical routine. So our idea is to make this test, a similar test, available through a web interface, and of course without a laser pointer. We indeed want to use a standard camera and face tracking methods to perform this same test. Previous work that we done as part of this project was to develop basically a robot that we use to evaluate the accuracy and the reliability of the face tracking algorithm. So in this way we could impose known rotations of the neck through a mechanism with 2 servo motors, and we evaluated how reliable the system for measuring these angles was with respect to the known angles of this mechanism. We also performed a lab-based study where we have 22 subjects, and the results were similar among different movement rotations to other studies that we found in literature. Now in this case though, we wanted to repeat this test with participants being at home, and we wanted to evaluate how feasible and reliable this method to remote measuring neck proprioception is. As I said, the task is pretty simple, and it involves starting with the head in a central position, which is the target position, always looking straight in front of the person. Then the subject is instructed to move away in one direction, and then to match back the position, to match back to the target position, and clicking to confirm that they have matched as accurately as they could. After this click, the person, which has now the eyes closed, is asked again to move the head away from that final position, and after some movement the person can open the eyes again to move back to the center to start a new position. The eyes open and eyes closed shifting is to avoid that the person has any feedback about the final position, so about how accurately they were matching. Now, our software is built using a motion tracking library which uses webcam and skeleton tracking, and it's online and freely available. We have eyes and shoulder coordinates. I'm actually going to show you live how this software works. So I'm just going to load it now. Sorry, it will take 1 second. So this is the software that we used as a starting point. It runs on a website. And as you can see now, it sees me, and it also estimates the position of my shoulders, my eyes and nose. Now, starting from this library, what we built is a website, and this is exactly the website that the participants used. So as they started the experiment,
please sit in front of the camera, looking straight in front of you and click.
You see there is some, you heard some audio guidance, and then the person is sitting still and clicking to confirm the position.
Close your eyes and click.
Now it asks me to close my eyes and click. I do so.
Turn your head up as much as you can, and then turn back.
And I turn my head
to the starting position and click.
And back. This green dot is controlled by my head movement. And now I try to match. I'm with my eyes closed. And
now
I
move
click.
your head a little.
And it asks me to move my head.
Eyes open to the center.
And now to open my eyes and go back to the center.
Close your eyes and click.
So this was the task that I explained you. And this is the website showing how it works. Now, going back to the presentation, we had that participants, we had 11 participants, relatively young, you see 23 years of age plus minus 1. They assessed the website I showed you from their own, using their own hardware, and we were not interacting with the participants. So they were remotely recruited, and we are completely unaware of their identity. We asked them to participate on 2 consecutive days, and they actually did comply with this, repeating exactly the same task. There were 4 movements directions. So proprioception was tested after flexion, that is going down, extension, going up, left and right rotations. And each direction was repeated 7 times, but we discarded the first as familiarization. There was no feedback of their error, so that there was no reason why subjects would have improved from day 1 to day 2, and across trials, of course, within one experiment. After each of these trials, we measure 2 quantities. One is the absolute error, which is the distance, so it's unsigned, between the final position and the target, so the center. The constant error measures a difference, it's a sign difference, and so it measures also the tendency to over or undershoot the target. Now, for each subject, we considered how long it took them to complete the experiment as a measure of feasibility. We measured the average, absolute, and constant error in each direction, and we measured we used t-tests to compare paired samples t-tests to compare the difference between the 2 days, and we used blend-Altman analysis, a method to determine the level of agreement between 2 measurements. Now, our first results are about the feasibility of our system. And of the 11 subjects, it took a range from 240 to 520 seconds to complete the experiment. There was a significant decrease between day 1 and day 2 from 400, so that is almost 7 minutes, to 312 seconds, approximately 5 minutes and 12 seconds. And these may have been some familiarization of the subjects. Indeed, if you notice, all the individual subjects took less time on the second day to complete the experiment. Now, when it comes to the absolute error, which is a measurement of the accuracy with which the subjects can match the target, we had that one subject had a significantly worse performance than the others. And as this was outside the 3 times the standard deviation of the group, we discarded this subject. We are not, it's not possible not knowing, for instance, what hardware they were using, whether that may be one of the reasons for this data to be a clear outlier compared to the other participants. So when it comes to the reliability, we measure this absolute error average across all directions for each subject. And here we show the average between the 2 days for all the subjects. There is, of course, no significant difference, as you can see, no visible difference between the 2 days. And the value that we measured, 3.6 degrees, is in line with what other studies report as the error that healthy subjects normally perform in this type of tasks, which are also called repositioning tasks. Now, this diagram is a Blend-Altman plot, and for those of you who may not be familiar with this type of analysis, it is useful when there are 2 repeated measurements or 2 measurements of the same phenomena. And we have on the horizontal axis the average between the 2 measurements for each individual subject. So each point is a subject. On the vertical axis, we have the difference between these 2 measurements. So if the measurement was the same for all subjects between day 1 and day 2, all the points here would have been on the horizontal axis. The level of the Blend-Altman level of agreement represents a 95% confidence interval for the measurements. So that is a sort of measurements of error of the measure. Again, if you considered if all subjects had exactly the same measurements on day 1 and day 2, they would have been here. So this interval, here represented by the dashed line, would have been of 0 width. So what we have is that our method has a very low, or we can say no bias. It's 0 degrees, less than 0.1 degrees. And the level of agreement is 1.67 degrees. Now, that is basically meaning that if we took 2 subjects and repeated day 1 and day 2, for a healthy subject, this difference in 95% of the cases would be in range 1.68. Now, as the difference, other studies have investigated what is the difference when using the standard method, so the laser pointer, between healthy and individuals with chronic neck pain. And the difference was above this uncertainty level that we have with our system. We also looked at whether this absolute error changed with different movement directions. And in fact, that was the case. We had that after flexion movements, the error was much higher. This may also be, it's not surprising that different methods lead to different errors, but as we don't have a gold standard to compare with, it is also possible that our method fails to measure accurately the angles after flexion. That is based on the camera tracking and the shoulder and eyes coordinate that we used. You also observe the difference between left and right rotation, which is even higher when we go to consider the level of agreement between across different directions. In fact, we had that in all directions the bias values were very low, but after left rotation we had a way higher level of agreement compared to the right rotation. This was somehow surprising. It may be related to our small sample size. So as you can see here, this single outlier may be the cause for that higher error. Also, in flexion as well, compared to extension, we have not only a higher error, as per the previous slide, but also a higher level of agreement, meaning that the system is performing poorly on flexion compared to extension. So, in conclusions, our work shows that with this tool we can conduct a remote and unsupervised assessment of neck proprioception. We are satisfied as our results with level of agreement show that its reliability may give the system some diagnostic value for diagnosing people with proprioceptive impairment. We can offer access to this website, which is at the moment restricted, but of course we are happy to collaborate on this, as it is just about sharing the link. And anyone with who's doing research on proprioception or in general on neurological conditions such as stroke and Parkinson's disease, which have for which some patients experience proprioceptive symptoms, are welcome to contact us, and we are really happy to discuss collaborations. So once again, thank you for your attention, and on behalf also of my co-authors, and thanks to EAI for hosting this e-conference, and to the organizing committee. Thank you. Please feel free to reach through my email for any question. I hope we also have the chance to speak here at the conference.
and welcome to the paper presentation for our paper Health Telescope, System Design for Longitudinal Data Collection Using Mobile Applications. My name is Bas Willemsen. I am a PhD student working on the project, and in the next 15 minutes I'll try to give you an overview of the paper and highlight some interesting parts that we discussed. We hope this is valuable for researchers looking into setting up longitudinal studies in the domain of e-health. In this presentation, there are some parts I will not go into a lot of detail for. If you would like more information on these parts, please do check out the paper. The presentation will follow a similar structure that the paper does. We start off by introducing the Health Telescope, the project that the system was designed for, expanding briefly on its goals. After that, we show the process behind the design system, by taking you through several steps we used to create the system. We start off by explaining considerations of the system design, then detail the implementation of the several parts of the system. After this, we show how the system is used to tackle use cases, similar to those that will occur in the study. Next, we discuss a small pilot that was held to evaluate the technical performance and user experience of our system, and we close off on the discussion, including changes made to the system based on the pilot, design guidelines that follow our experiences, and some limitations of our paper. Let us start with some background on the Health Telescope project. The Health Telescope is a study that follows 450 participants for a duration of 4 months, where users are given wearables, have their activity tracked, and are recommended e-health apps to use. We aim to find out more about the long-term effects of using e-health applications. Furthermore, we aim to learn which applications are effective for which participants. Participants are given a Xiaomi Mi Band 2, a wearable device tracking activity. During these 4 months, participant activity as well as brief daily surveys on participant mood are gathered. Once per month, participants will receive a message requesting them to download and use one of several e-health apps targeted at increasing physical activity. By tracking activity and mood, we aim to get a better understanding of the effects of using these applications. On this slide, you can see the recruitment over time. Each column indicates a month, showing the number of active participants in the treatment and control groups over time. Assuming a recruitment of 150 participants per month and the decay or dropout rate of 0.2 per month, we will have a total of 295 participants in the 4th month. While recommendations in the first months will be distributed randomly, the data gathered in the first 3 months will be used to predict which app might work for which user in the 4th month. In doing so, we attempt to personalize this offering and match a user with an app that is likely to be effective for them. The data gathered is as follows. We collect the wearable data, hourly steps taken, hourly samples of the heart rate of participants, and daily summaries of sleep data. We furthermore gather GPS data and data on active services on participant cell phones. Lastly, as mentioned, participants will be asked 3 daily questions on their mood. The Health Telescope study has 3 objectives. Objective 1. We aim to investigate the effect of using e-health apps focused on increasing physical activity on activity and mood for a long period. We specifically aim for a longer period of time than is seen in many studies, as the behavior change that e-health apps often aim to accomplish are complex processes that require time to change. Objective 2. We want to see if there is a correlated effect between short-term measures and long-term measures after interacting with e-health apps. If we are able to find correlation between short-term measures, such as the use of an e-health app within a week after download, and the change in activity after 4 months, it becomes easier to match users with apps. And Objective 3, we want to test different ways of personalizing e-health offerings. As explained, we will use the collected data from the first 3 months to recommend apps that we believe are effective for users in the 4th month. Let's talk a little bit about the system architecture and implementation. The system designed to run this study needs to gather participant data, allow researchers to easily communicate to participants and navigate through collected data, and store all of this data securely. As a result, the system can be described in the following 3 parts. We will have a mobile observer app, an application that collects the aforementioned data. This app will only be available on Android OS due to Apple's data accessibility limitations. We'll have a web client that allows researchers to schedule documents to be sent out to participants and navigate through the data. And lastly, we'll have a central database where gathered data is stored securely. Important to mention here is that the mobile app is meant to A, transfer wearable and phone data to the database, and B, help evaluate existing apps. It is not an eHealth app itself and does not give users feedback on their activity. Let's talk about the implementation of the mobile app. The app serves 5 goals. Firstly, to serve as a tool for users to self-report on their mood. Secondly, to gather GPS and phone usage data. Thirdly, to collect sensor data from the wearable band, visually display this data and transmit collected data to our servers. Fourth, to deliver interventions to participants. And fifth, to monitor participant engagement. On this slide, you can see the home screen of the application. It provides a simple overview of recorded data and has the wearable control panel below that. Furthermore, it contains an inbox for uncompleted tasks and questionnaires. The app also includes a settings menu where data access permissions can be changed, as well as a frequently asked questions screen that can help users solve some issues. The mobile application is a hybrid of a web-based component and a native Android component. The web-based component is an Ionic or Angular app, which renders the user interface and also renders the questionnaires or other documents created by the researchers. The user interface consists of 2 major parts. One is a setup guide to allow participants to log in and manage their system account, provide necessary permissions for data collection, and pair their wristband with the phone. The other is the main screen, which displays documents available for access, as well as an inbox screen for notifications received so far. Notifications are Firebase cloud messages that can consist of a single message body, but can also have documents attached. All documents in this environment can be any HTML or JavaScript content, which gives researchers the freedom to serve rich stylings and interactions according to the needs of the study as it develops. Data is stored in the phone's SQLite 3 database and is only uploaded to the server at opportune moments, as decided by the Android OS's facilities for managing communications and power consumption. Now let's talk a little bit about the client. The client serves 3 goals. Firstly, to monitor enrollment and participant engagement. Secondly, to conduct experiments by setting up scheduled surveys and alerts. And thirdly, to communicate to participants. The paper describes how the web client is set up, explaining the different concepts like participant groups, documents, allocations, and rules that can be used by researchers to distribute information to participants or set up surveys. The authoring web application was built using the Ionic and Angular framework. On this slide, you can see a screenshot of the web client. While working within the environment, new screens will come up in the form of these panels that allow quick navigation between panels. The screenshot shows the creation of a document, which can be done in HTML. The preview button on the bottom right shows a live preview of the compiled code. Next, the paper gives examples of how the system can be used to easily carry out tasks in the study. We demonstrate this for 2 different use cases and show in great detail for each of them the steps needed to complete the tasks. The 2 use cases are: Use case 1, questionnaire. Set up a questionnaire that asks every participant in the panel 3 questions daily for the next 3 months between 11 a.m. and 8 p.m. And use case 2, intervention. Send out a cloud message containing advice to download an interventional application to participants that walked an average of less than 7,000 steps per day for the last 30 days. We will briefly go over the steps needed for these use cases. A detailed description, including screenshots of these use cases, can be found in our paper. For use case 1, there are 4 steps that need to be taken. Firstly, we have to create a document in the authoring client to distribute to participants. Then, we select a group containing participants that will see the document. After that, we create a rule that makes this document appear within a time frame, and then we tie everything together by creating an allocation that will send the document to participants. For use case 2, we have to create a group of participants that will receive the intervention, then create a document containing the intervention, and lastly, add the document to a cloud message that will be sent to the group of selected participants. As I mentioned, for more detail on these use cases, we recommend you to read the paper. During the development of this system, we made use of multiple small targeted tests or pilot studies to evaluate implementation and guide our direction for the system. We describe one of these pilots in the paper, showing how the pilot was set up, what feedback was obtained from the pilot, and what lessons learned from the pilot were. In a broader sense, though, we aim to show the value of these short pilots before a system is fully ready, in evaluating how user-friendly a system is, make any technical issues visible, etc. The design for the pilot is as follows. First, the intro survey, where participants complete the introductory survey, including questions on personal background and measuring some psychological constructs. Then the installation, where participants download and install the mobile application. The setup. Participants log into the app, set their data preferences, and set up the connection to the wearable. After this, the setup is done and participants are enrolled in the pilot. Next, there is a daily survey, where every morning the participants receive a notification to fill in the 3-question survey. After 3 days, there is intervention 1, where participants receive a cloud message containing an app recommendation for an eHealth app. And after 10 days, there is intervention 2, where participants that have not installed the application recommended in intervention 1 will receive another cloud message containing a recommendation for a different health app. Recruitment for the pilot took place through a health insurance company, with all respondents being employees. 7 respondents expressed interest, however 3 respondents were unable to participate. The remaining 4 participants were 34 years old on average, and the briefing documents that were supplied are listed in the paper and can be found on healthtelescope.com/documents. The pilot concludes with individual, semi-structured interviews with each participant. During this interview, we have specific points on which we would like to gather feedback. Feedback from the pilot was expected in 2 main categories: technical functioning and user experience. Regarding technical functioning, developing apps that function on a wide range of Android phones can be tricky, especially when Bluetooth is used, because Bluetooth functionalities cannot be tested in Android Studio virtual machines. As such, both internal testing as well as several pilots that were held aim to detect any technical issues before launch of the study. Regarding user experience, we aim to test each action that real participants will take in the pilot, so as to find out more about the strain of participation and possible improvement points for this. This includes the briefing and information supply, as well as the effort needed to answer surveys, use the wearable, etc. The paper describes the results for these 2 categories: reporting on the software stability, data transfer, functioning of messaging and documents, technical functioning of the wearable, and general user experience. We include translated quotes from the interviews with pilot participants. The main findings were as follows. Technical stability needed to be improved on several fronts, as participants were at times unable to sign into the app or receive documents. Data transfer functioned as expected, and the wearable data collection was accurate, except for 1 participant that likely received a malfunctioning wearable, reporting abnormally high step counts of over 20,000 steps per day on average. User experience throughout the pilot was mostly okay, although the app was not as user-friendly as some commercial wearable apps. Additionally, participants could use some more structure in the setup. For a more extensive overview of the pilot and its results, we refer you to the paper. The discussion contains 3 components. We firstly describe the changes made based on the pilot. Then we include a lengthy section on related work that might be interesting for researchers looking into setting up similar work of their own. And lastly, we delve into a number of design guidelines for similar longitudinal research based on their own experiences. That finishes the presentation on our paper. We would like to thank you for your attention. In case there are any further questions, please do not hesitate to contact me. My email address can be found on the slide.
Hello, and thank you for tuning into this presentation. My name is John Templeton. I am a graduate researcher at the University of Notre Dame in the Mobile Computing Lab within the Department of Computer Science and Engineering. The title of this talk that I will be presenting on behalf of all authors is the design of a mobile-based neurological assessment tool for aging populations. In this presentation, the motivations for this work will be addressed, followed by a brief introduction and related works of current versions of clinical assessments. Next, the methodology for participant recruitment and subsequent data collections will be covered. Then, the results both in terms of usability and cognitive interference analysis will be followed by a discussion on how this information can be used to update overall task design and mobile-based neurological assessment tools in the future. Finally, a brief set of conclusions and future research will be presented. The motivations of this research are threefold. First, this work is to address the issues of usability and efficient design of neurocognitive assessment systems, both for aging populations and those with recognized neurodegenerative conditions. Second, this work includes the proposal of design updates for user interfaces, specifically in testing instructions, layouts, and user interactions. And third, this work is to explore different task designs and the potential benefits of cognitive interference on task performance. These motivations can be better understood with the inclusion of background knowledge on clinical neurological assessment systems. Typically, as an individual is suspected of having a progressive or acquired neurological condition, a cognitive screening assessment is given. However, with the transition of these clinical cognitive screening assessments from pen and paper-based versions to mobile-based versions, there is the potential for usability issues based on user conditions. These neurocognitive assessment instruments focus on subparts or functional areas of neurocognition, including motor, memory, speech, and executive functions. Therefore, both efficient and targeted application designs of neurocognitive assessment systems are needed to allow for the accurate assessment of each functional area of interest, as well as across all populations. The methodology section for this work will also be used to give a better understanding of functional neurological assessment systems as related to the previous material covered. This is intended to include both aging populations as well as individuals with neurodegenerative diseases. In this study, 40 adults participated who were between the ages of 52 and 84. These participants consisted of two groups, those with a confirmed diagnosis of Parkinson's disease, as well as aged matched healthy controls. This work focused on individuals with Parkinson's disease since they demonstrate impaired functionality of both motor and cognitive tasks. All participants were required to complete a set of mobile-based functional tasks commonly administered in neurocognitive screening assessments. These tasks include tracing a set of shapes for fine motor function, object manipulation for gross motor function, card matching for memory, and trail making tasks to assess executive function. Further, dual task assessments were implemented where an aforementioned functional task was done in tandem with a non-automatic speech task. Each participant was instructed to interact with versions of the following functional tasks as seen in the figure below. All listed mobile-based task versions seen below are commonly included in current clinical assessments. These mobile versions had instructions persist on the screen so users could refer to them as necessary as they completed the task. All interactions were located on the same page to minimize navigational efforts, and bottom navigation bars were included on all pages. Different task versions also implemented modes to examine the effects of cognitive interference. Cognitive interference is the addition of outside stimuli that intrude on task-related activities. Modes of cognitive interference include either visual cognitive interference, using new shapes, patterns, and/or colors, or dual task interference. An example of dual task interference is seen below in the right half of the figure, where the user has to complete two tasks in tandem. The dual task implementation for both fine and gross motor functional tasks prompted users to trace or emulate a shape, which was depicted on the device screen, while also doing a non-automatic speech task. The non-automatic speech task was to list all months of the year in reverse chronological order, starting from December. The next set of slides will explore the results, both in terms of usability and cognitive interference analysis. Overall usability was assessed by gathering the number of incorrect screen interactions between groups. This could be done in terms of navigation or by interacting with the screen in a way that was not depicted by instructions or demonstrations. The 40 participants took a total of 1,170 tasks using administered mobile devices. 884 of these tasks were taken by individuals with PD. In the table below, participants with PD had 598 task interactions in a baseline assessment. Of those 598 task interactions, 5.02% had at least one incorrect screen interaction. When a representative population of the PD group took the assessment again, interacting with a total of 286 tasks, 3.15% of those tasks had at least one incorrect interaction. Although there was a perceived decrease in these incorrect interactions from baseline to second version, they were still much higher than the instances in the control group at 0.35%. For the understanding of cognitive interference on task performance, two versions of each task were implemented, one with and one without interference. To understand how a function is affected with cognitive interference, it is necessary to understand that same function without. These two versions or configurations were intended to understand if any objective metric significance differed based on the implementation of that cognitive interference. In card matching for both configurations, the user was prompted to interact or flip cards until they had matched all pairs on the screen. Version A, without cognitive interference, had all pairs of cards with unique colors and shapes, whereas version B implemented cognitive interference. This was seen as all pairs of cards had unique shapes, but only two colors, red and black. The significance of both timing metrics was maintained in both versions, with p-values being less than 0.05 as seen on the table on the right. In trail making tasks for both configurations, the user was prompted to use their finger to draw a line connecting shapes in increasing order of numerical count. Version A, without cognitive interference, had all shapes the same, as is the shape fill color, whereas version B implemented cognitive interference. All shapes were unique and had differing fill colors, which was intended to be an outside visual stimuli. Significance was maintained in both versions for time and total points drawn. However, in version B, the average distance to a true value point, or the center of the depicted shape, no longer separated the two groups as a significant metric. This can be seen in the table where the p-value is 0.457 in task version B. In a fine motor task, the user is prompted to interact with the screen by tracing a shape with their finger. The significance was maintained for both time and total points drawn by the user in both a single modal tracing task and its corresponding dual task version, which included a non-automatic speech task. All p-values in the given table were observed to be less than 0.05. In the gross motor task set, the user is instructed to manipulate the mobile device and air trace a prompted shape. The metrics in this task, however, showed that significance values were different between both single and dual task versions, as seen in the table on the right. Timing metrics were significant for the single modal task, whereas acceleration metrics were significant in the dual task version that included a non-automatic speech task. The following slides will discuss how the collected information can be used to update mobile-based neurological assessment systems. With the collected results from the usability perspective, updates to mobile applications for aging populations, specifically those with neurological conditions, need to be made. These updates should attempt to reduce the number of incorrect interactions of the PD group closer to the level of control populations. Sample updates from the depicted figure on the left can be seen on the next slide. Updates included were completed for both task instruction and task layout. For task instructions, a separate view was created that allows for short text descriptions and video demonstrations instead of static representations, all of which can be viewable anytime by including a drop bar menu. This can be seen in the left half of the figure. In task layouts, all button interactions were moved to the top of the screen to minimize navigation errors and incorrect screen interactions, while the removal of instructions on the main page allows users more room for task interactions. This can be seen in the right half of the figure. At the task level, understanding task performance and the implementation of cognitive interference also calls for updates. The following slides will depict when certain implementations should indeed be used. Further, the figures on the left in all the following slides include functional task updates expressed previously for both instructional views and interactive views. As seen on this slide for card matching, both versions yielded the same significance metrics for both tasks, therefore either task version could be implemented. However, in trail making, the visual interference actually reduced the number of significance metrics between groups. This prompts a task version without visual interference, using all the same shapes and fill colors to be included in an assessment tool. This is seen in the figure on the left. For fine motor tasks, metrics for timing and total points drawn were significant in the single modal task version. However, in this case, there are benefits for the implementation of a dual task version if time is available. Version A of the fine motor task had a significantly shorter duration than the dual task version for both groups. However, version B includes more collected metrics that can be obtained, including frequencies from actual speech samples and/or word counts. Therefore, both task versions have been updated for the application based on these constraints. Finally, for gross motor tasks, timing metrics from the single task version were significant, whereas the metrics for magnitudes of acceleration were not. However, the inverse can be seen in the gross motor dual task implementation, as timing metrics were no longer significant, but two metrics of maximum and minimum magnitudes of acceleration were. In this case, both single and dual task versions for gross motor function should be implemented, as different metrics showed significance for both tasks. Both task versions have therefore been updated for application usage. Overall, updates and assessments that use traditional layout methods, including bottom bar navigation menus or hamburger menus, need to be further explored for aging populations with recognized neurodegenerative diseases. For example, populations with motor impairments, specifically individuals with PD, have significantly reduced finger pointing performance due to sizes and locations of typical intended interactions. Similarly, desired outcomes of neurological assessment is the version that yields the highest number of significant metrics between groups. Therefore, functional task updates based on cognitive interference should also be included. For example, dual task interference allows for more objective metrics to be collected and also provides different significant metrics compared to single task versions in some cases. Further, these dual task versions also allow for the collection of insights of a user's task prioritization. In conclusion, based on the findings in this study, a focus should be placed on updating mobile assessment instruments for both usability and task performance. These include layout updates to minimize incorrect interactions while maintaining accessibility to all necessary instructional information. The transition from clinical pen and paper style assessments to mobile-based versions have many new technical considerations, especially as overall application development should focus on all possible users. Further, this work can be expanded to other neurodegenerative conditions in the future. A short list of references has been provided for the purpose of this presentation. However, for the complete list of references, please refer to the corresponding paper in the upcoming conference proceedings. I would like to take this opportunity on behalf of myself and the other authors of this work to thank you for your time in listening to this presentation entitled Design of a Mobile-Based Neurological Assessment Tool for Aging Populations. If there are any questions, feel free to contact us.
Hello and welcome to the presentation of our paper, Experiences in Designing a Mobile Speech-Based Assessment Tool for Neurological Diseases. The authors are myself, Louis Daudet, Computer Science PhD at the University of Notre Dame, my advisor, Dr. Christian Polabauer from the University of Notre Dame as well, and Dr. Sandra Schneider from St. Mary's College. So first, a little bit of background and motivation. 10 million people live today with Parkinson's, and 250,000 people are estimated to be living with ALS. That number is expected to rise to almost 400,000 people by 2025, making our work all the more important and impactful. Finally, age is the most influential factor for those conditions, so the rate of incidence of these conditions is projected to increase with the aging of the population worldwide. Now, a little bit about speech. Speech is a very complex task involving several areas of the brain. 3 different stages of speech production have to be noted: motor speech planning, motor speech programming, and motor speech execution. Now, the conditions that we're analyzing are expected to leave a unique signature in each of these areas, signature that we're hoping to then be able to identify so that we can classify based on speech samples, the different populations. Now, let's listen to an example. We have here 2 participants, one with Parkinson and a control.
Do you like amusement parks? Well, I sure do. To amuse myself, I went twice last spring. My most memorable moment was riding on the Caterpillar, which is a gigantic...
And now for the other participant.
Do you like amusement parks? Well, I sure do. To amuse myself, I went twice last spring. My most memorable moment was riding.
Now, without too much surprise, patient A was control, while patient B had Parkinson's. We can hear clear differences in their speech. The question is there a way these differences can be of use? So, the presentation plan for this presentation will be: in part 1, I'll go over the application design. In part 2, the challenges in the design. And finally, in part 3, the results of the data collection. So, for the application design, we had several speech-based tasks that we use. Voyal test, diadoconnectic rate test, or DDK rate test, a grandfather passage reading, monosyllabic words and increasing syllabic words, a picture description for the volitional speech, multisyllabic word, sentences, and finally automatic speech production, counting to 30, the days of the week, the months of the year. Now, for the details on each of those tests, I'll refer you to the paper. We'll just go into the detail of a few of these tests in this presentation. So first, the diadoconnected rate. So here, we ask the participants to go through a series of pa, ta, ka, and then pataka, where they have to get as much of them produced in a limited time, here 5 seconds, and we'll then be counting the number of utterances for each of them. This is designed to be testing the sequential motor rate and the alternative motor rate of the patient. We also have the grandfather passage, where here the patient is asked to be reading the grandfather passage. We are here checking for the capacity of the patient to handle running speech and the ability to join sentences together. Can he have the correct intonation than the other sentences, especially with questions and exclamations? Are all the phonemes present in the passage too? So a lot of norming data exists, such as the time that it should take to read it, allowing us to detect outliers. And finally, we have a picture description test. So here, a picture is selected at random from a series of pictures, and we ask the participant to describe the picture with whatever vocabularies they choose. This is checking the patient capacity to handle volitional speech with the extra cognitive load that it entails to construct the sentences before actually pronouncing them. The reason we had a different picture, like an array of 10 different pictures, is that some of our participants took the test several times, and by having one of pictures selected at random every time, it keeps the test new for them, and so they don't they can't rely on whatever they've said the previous time when they saw the picture that they already saw the first time. So it keeps the speech entirely new every time. Finally, to go with all the speech-based tests, we collect a lot of data about the participants, such as their gender, the patient native language, so that we can deal with accents, the age, if the patients have a condition, when was the last time they take their medication, if they have Parkinson, all kind of data that will help us both extract the metrics from the speech sample more accurately, and then be able to correlate the results of the metrics with whatever the condition of the patient was and where they were in their medication cycle. So now we're gonna move to the challenges we faced when designing this application. So the first one was the user handicap. So the problem was that, especially with patients with ALS, we noted that some patients were not able to go through the list of tests. So we worked to reorder the test in the order that is now displayed on the screen, so that we could have the best ratio of quality tests, as in the most impactful tests that we have noted in our preliminary data collection to be impactful and generate metrics that had high classification power, and that would allow the ALS patient to go through as much test as possible before not being able to go on further. So that was sort of a trial and error where we had to test different combination in different ordering to arrive at that order where we noted the best ratio of ability to go through the test and quality of the metrics extracted from the test. The second challenge we faced was the user prompts, how to convey to the participants what was expected of them. That was a lot of challenge there because of the different tests and the different ways they were to be performed. So here you can see on the leftmost side that we have a test that has to deal with time. So we expect there the patient to produce the sound ah for 5 seconds. The way we did that is by first prompting them orally that we expect them to say ah for 5 seconds, as well as having the text of the screen. And then when they press the next button, they saw the screen that you see here with a timer that count down from 5 seconds to 0, and the red recording line letting them know that they are being recorded and know it's the time for them to say ah. For the test where we have words or sentences, we will hear first say the word or sentences on top of having it on the screen. And after they heard the word or sentence, the screen will switch from gray to red with the recording sentence to let the participant know that now it's their time to repeat the word or sentence that they've heard. Finally, for the picture description, we wanted to make sure that the participants always had the iPad in landscape mode. And so we realized that having to switch it manually at the when we reached that test was not very practical. So instead, we had the test stop if it detected that it was in portrait mode, and it will only continue when you would turn the iPad to be in landscape mode, and then it would display the picture, give you an oral prompt that you're expected to describe the picture, and finally switch to red to indicate that the application was recording. With all that in, the participants were able to go through the test independently with very high accuracy. Now, another problem that we faced was the clipping of the recordings. When we first started the data collection, we had for each test one recording created for every part of the test. So if a test consisted of 10 words that we expected the participant to say, we would have one recording per word. The problem here is that the participant would often start a little bit before they should and often press next as they were finishing the word, leading to a lot of clipping of the recordings, making them unusable. So the solution we came up with was to instead have one long recording per test and then track the time at which the user had any input on the test. So when they would press next, we would, to go from one word to another, would record the timestamp. When the application was done uttering the word or sentence, we will track that time as well. And when the patient will be done with saying the words themselves and then pressing next, we will record that time. What it would give us in the end is one long recording with no clipping at all, along with the timestamp so that we can know where we expect the patient to be talking within that speech sample, so that we can then concentrate our analysis within those boundaries, allowing for a little margin on each side of where we expect the patient to be talking, by about 50 milliseconds on each side, so that we can make sure that there is no clipping here. Another issue we ran into was user error. So a lot of times when doing the data collection, the user would make mistake at one test or another. The problem there is that initially the only way to handle this was to finish going through the test series and then come back and revisit each of the tests that didn't go well. The problem that we faced then was that on top of not being very efficient, we would keep the original erroneous sound file within our pool of data collected, making it tricky for us to then later on know which files were in error and which files were analyzed. So the solution here was to introduce this screen at the end of each test, where we have the option to either press next and go to the next test if everything went well, or to press redo, which would both go back to the beginning of the tests that were just completed and also erase the original recording that we knew to be erroneous, so that we didn't keep track of it and keep our data pool of speech sample clean. Finally, the last challenge that we faced was the data handling. So because this was sort of very sensible data, HIPAA data, medical data, we needed to make sure that the security was up to par. So we went at it several different ways. For one, we encrypt everything on the device. Then while in transit, we use HTTPS to encrypt all of the data as it goes from our iPads, where we collect the data, to our backend servers. Then the backend servers themselves were very secure and placed behind several layers of firewalls. And finally, as a last layer of security, when we upload the data off of the device, we first anonymize the data and send in one server all of the data collected except the anonymous information, and on another completely different server, the anonymous information only, so that if by any chance either of those servers were to be breached, we would either compromise data but with no anonymous information, or compromise anonymous information, but that would just be the name of the participant and no data associated with that. So we're now in part 3 of this presentation, the results of our data collection. So the data collection ran between November 2015 and March of 2019. 64 different individuals participated in the data collection, leading to 509 minutes of recording, with 446 of those being usable for analysis, and the rest being compromised recordings that are either clipped or erroneous altogether that couldn't be used. To give you a breakdown of the recordings per condition, so the bulk of our data collection was from Parkinson's patients, with almost 50% of the data collected coming from Parkinson's patients. And then the rest was split almost evenly between control and ALS patients. Finally, to give you another view, but this time on gender repartition, 56% of the participants were men, while 44% of them were women. Now, for the most sort of important part of our presentation is the improving recorded quality from version for the different version of our application. So as you can see, the first version of the application had only about 65% of the recording being usable. And as we improve the application version after version, we were able to get that percentage of usable recording above 90% for the last version of the application. Thank you for your attention, and we invite you to read the paper for more details in our work, and to look out for our next paper where we'll go through the results that we've gotten from those speech sample, both on the data extraction from those speech sample and the modeling work that we're going to do to classify those different metrics into the different conditions that lies behind them. For any question, please do not hesitate to send an email at l.day@nd.edu. Thank you for your time. Goodbye.
Hello everyone. Today we are going to present our work on patient-independent schizophrenia relapse prediction using mobile sensor-based daily behavioral rhythm changes. This is a joint work between Rice University, University of Washington, Dartmouth College, Cornell University, and Northwell Health. And I'm Vishal Lamichane presenting this work on behalf of the team. Schizophrenia is a chronic mental disorder where patients have abnormal perception of reality and therefore show disturbances in their thoughts and behavior. It is characterized by several symptoms such as delusions, hallucinations, reduced speech, and social withdrawal. Schizophrenia is a widely prevalent disorder affecting many people worldwide. In one of the latest estimates, it was found that up to 20 million patients are affected by this disorder. For a patient diagnosed with schizophrenia, there are pharmacological and non-pharmacological treatments to manage their symptoms. However, sometimes this patient would experience relapse. So what is a relapse in context of schizophrenia? A relapse is an incidence of increased schizophrenia symptoms for patient in course of treatment. A relapse has an adverse impact not only for the patient, but also their caregivers and families, sometimes even endangering their lives, as some schizophrenia symptoms relate to dangerous and violent behaviors. Therefore, it is highly desirable to detect an oncoming relapse so that appropriate and timely intervention can be provided. Towards this goal of schizophrenia relapse prediction, we investigated mobile sensing-based solutions. So, can mobile sensing be used to detect an oncoming relapse? We believe that mobile sensing is relevant for schizophrenia relapse prediction because many schizophrenia symptoms are related to behavioral changes. For example, in terms of the degree of social withdrawal with changing social communication patterns, changes in motor function, changes in mobility behaviors, etc. And mobile sensing with the use of several mobile sensors such as accelerometer, light sensor, sound sensor can help measure and quantify behavioral changes of patient. The sensor-based measurements in mobile sensing can be complemented with self-assessments done with EMA or ecological momentary assessments. With EMA, patients are able to provide self-reports of their emotional states periodically. We investigated mobile sensing-based relapse prediction using now publicly available cross-check study dataset. In this study, 63 schizophrenia patients were continuously monitored for up to a year with different mobile sensing data. Besides the sensor data, self-reported assessments with EMAs were also obtained few times every week so as to measure the patient's emotional state like their calmness, sociability, stress, etc. From among these 63 patients included in the cross-check study, 20 patients had relapse, and there are a total of 27 incidences of relapse in this dataset. Therefore, some patients did have multiple instances of relapse during their monitoring period. The patient's clinical information are also available in the cross-check study dataset. Besides the extensive clinical notes and annotation about the patient, there is also the clinical information of BPRS scores. BPRS, or Brief Psychiatric Rating Scale, is a standard clinical questionnaire to keep track of schizophrenia symptoms. When we looked at the mobile sensing data within this cross-check study dataset, in relation to relapse prediction, we had some encouraging assessment based upon qualitative analysis. As an example, here we show the obtained data on average call duration for a particular patient. The average call duration is an indicator of sociability behavior. And for this particular patient, this data is shown here in the orange during the monitoring period here. There were 3 incidences of relapse for this particular patient. This is shown here with the black dotted line. As you can see, there is an increased and changing activity in call duration closer to the relapse period, most markedly on the second and third incidences of relapse. With this qualitative assessment giving encouraging results, we investigated machine learning model for relapse prediction, because machine learning provides us a framework to combine multiple modalities of sensor data and EMS towards a robust relapse prediction model. So, within our machine learning based relapse prediction approach, we treat relapse prediction as a binary classification problem. We use the mobile sensing and EMA data from 4 weeks to predict if there is an oncoming relapse in the next week. The period of 4 weeks was chosen as previous work has shown that behavioral changes start to appear up to a month before relapse. We developed a sequential prediction model evaluated in a patient-independent test setting using leave one patient out model evaluation. Such sequential patient-independent model are closer to clinical deployment scenario but has never been investigated before in context of schizophrenia relapse prediction. The 4 weeks of mobile sensing data that are used in relapse prediction are characterized with different features to quantify, for example, the daily rhythmic behaviors. Let's look at some example of how we characterize this mobile sensing data within the feature extraction window to be represented in our machine learning model. For example, for our daily template features, we first obtained the hourly average of mobile sensing data for each of the day. Here we show an example for the mean ambient light sensor data. Here we see the template obtains for 2 consecutive days, and each of the template consists of hourly averages. Therefore, there are 24 points in total for each of these daily templates. And within a feature extraction window, we then obtain 28 different templates corresponding to each day. Now, these 28 different templates within a feature extraction window are summarized with a representative template, one for each feature extraction window of 4 weeks, using different approaches. For example, we computed the average of these 28 different templates to obtain a mean template, but also characterize the deviation in them to obtain the deviation template, and also the maximum template characterizing the maximum values in a given hour across the 28 days. Now, these representative templates for a given feature extraction window are further characterized using different statistical features which then fit into the machine learning model. We use statistical features like the mean, the maximum, kurtosis, screenage, but also we computed how these representative templates differ across the feature extraction windows using feature based on the template distance. Thus, we computed several daily rhythm features using the mobile sensing data. We also used the EMA data within the feature extraction window of 28 days, and represented this EMA data using their mean and standard deviation across all the EMA item values, of which we have 10 in total. For example, characterizing their calmness, their stress within this feature extraction window. We also included demographic features to allow implicit personalization of the machine learning model. Now we have a way to characterize the mobile sensing data within the 4-week of feature extraction window. As for our machine learning model for relapse prediction using these features, there are some unique challenges associated with our framing of relapse prediction as a binary classification problem in a machine learning model. For example, we have only a few instances of relapse compared to non-relapse period. This makes this a highly imbalanced dataset for learning. Similarly, there are individual differences in behavior and relapse characteristic across the patient. This might make our relapse model challenging to learn and generalize when we use machine learning models. We tackle these challenges in the modeling domain. As for the imbalanced dataset, we compare and use machine learning models that can learn in presence of class imbalance. And for personalization, we use demographic information to personalize a feature set toward a particular patient. Let's look into that approach in further detail. So how do we personalize our model for a given test subject? Let's say we have a patient in test set for whom we are developing a relapse prediction model. We first identify a patient subgroup in training that are closest to the test patient in the demographic space. In our work, we use the age information for this identification of the personalization subset. Now, the machine learning model that is developed towards a test subject is personalized by fine-tuning and selecting features that are most predictive for relapse prediction in this personalization subset. Thus, this approach allows us to personalize our model towards a test subject for whom we are developing a relapse prediction model. Now, using this personalization model and this evaluation setting that we discussed, we compared different machine learning models to see which gives us the best relapse prediction performance. We compare our machine learning models in the F2 metric space. FT score summarizes the precision and recall value obtained with higher priority for recall. Thus, in our problem setting, detecting a relapse is slightly prioritized over generating a false alarm. And the results obtained with different classifiers for relapse prediction are shown here. We obtained the best relapse prediction performance using a simple naive Bayes based classifier. It gave us a F2 score of 0.083, which is much better than what we obtained, for example, using ensemble learning approaches, for example, balanced random forest and easy ensemble, which learns in presence of imbalanced data. The naive Bayes based model also performed much better than isolation forest, which are based upon one class classification concept. This F2 score of 0.083 is low, but if we compare that to the random classification baseline, the results are quite significant. This random classification baseline is obtained by randomly labeling a window as relapse or non-relapse. Thus, since the score of random classification baseline is only 0.02, we think the score obtained with naive Bayes is quite significant and characterize that the mobile sensing data has predictive value for predicting an oncoming relapse. When we compared the relapse prediction pipeline with features from individual sensing modalities, the best prediction results were obtained with mobility features based on distance, emotion-related features based on EMA, and sociability feature based on call duration. However, if you look in the obtained F2 score with this individual sensing modalities based relapse prediction, we see that none of the individual modalities give a high F2 score. Thus, we conclude that multimodal approach of combining different sensing features are highly relevant for schizophrenia relapse prediction. Also, In our work, we retained the hourly sensor data when we developed features characterizing a feature window. However, in one of the previous work for schizophrenia relapse prediction, it was proposed to summarize the sensor data within a 6-hour epoch to develop feature sets. When we compared these two different approaches of developing features for characterizing a feature extraction window towards relapse prediction, we saw that our approach of using hourly representation of mobile sensing signals gave better prediction performance compared to the previous work where a more coarser representation of the sensor data is used. With our hourly sensor representation, we obtained a F2 score, as we earlier said, of 0.083. But when using the same prediction pipeline with the new feature set based upon coarser information, we obtain a F3 score of only 0.06. Thus, for relapse prediction, fine-grained behavioral information encoded in hourly changes of sensor data seems to be relevant and needs to be continued to be investigated in future work. To conclude, based upon our work, we see that mobile sensing indeed provides predictive value for detecting an oncoming schizophrenia relapse. We also found that the multimodal approach for detecting relapse is more fruitful compared to prediction using a single sensor modality. We also found that hourly sensor data characterizing the rhythmic behavioral patterns on a final level provides better prediction performance for relapse prediction compared to the coarser grained sensor data averages as proposed in the previous works. Nonetheless, the currently obtained F2 score that we reported in this work is low. Therefore, we need to investigate further to identify better discriminating features that can discriminate the relapse period better from the non-relapse periods. We also need to investigate improved classification models. For example, by studying what approaches are there to better personalize a model and adapt a model toward a particular patient and toward a particular relapse incidences. This work will be pursued in future. We'd like to thank you all for listening to our work. Thank you.
Dear audience, a warm welcome to my presentation today about my article Understanding E-Mental Health for People with Depression in Evaluation Study. My name is Kim Blankenhagel and I come from Berlin in Germany. There I'm working as a consultant at the Association of German Engineers, and before that I was a research associate at the Technical University in Berlin at the Chair of Information and Communication Management of Professor Dr. Zarniko. You can see the whole research team at the picture. We did a lot of research in the classical areas of communication and information, and in particular in the area of digital healthcare. Today, I want to talk with you about depression and about the integration of digital technologies in the therapy of depression. I will present my scientific study and I will show you the main findings. First of all, why is it so important to deal with the disease depression? We know depression is a severe and widespread disease with considerable effects on people's well-being and quality of life. Although evidence-based treatments, such as psychotherapy, are available for depressive disorders, a really significant portion of people afflicted with such disorders do not receive treatment or wait a long time for treatment to begin. At the same time, a large portion of the world's population uses the internet, with much of this usage being focused on health. Consequently, self-monitoring and self-management are becoming increasingly important, and digital health intervention have proven to be a promising way of supporting people with depression. These can be an effective complement to personal psychotherapy or pharmacological treatment and are particularly suitable for people who have insufficient access to psychological treatment or do not wish to get in personal contact with a psychotherapist. This contribution systematically analyzed the underlying factors that affect people's decision to use such e-mental health application to manage depression. we analyzed the usage of a therapeutic platform designed for the individual therapy and self-management of patients suffering from depression called SelfPath. SelfPath is based on a combination of algorithms for daily self-assessment and analysis of the patient's biosignal data and environmental information. SelfPath enables therapy by offering self-assessment of the severity of the patient's mental distress and by suggesting practical steps for self-management. This takes into account the integrated biosignal data, for example, the heart rate, and current environmental information, for example, the weather. Depending on his or her individual situation, the patient receives individualized guidance for self-management and therapeutic interventions. The structure of the therapy sessions varies according to the degree of the severity indicated. We tested SelfPath with a group of 98 participants in Germany. For each participant, the survey took place over a period of 5 consecutive days, during which the participants used SelfPath daily for a period of around 30 minutes. Each day, participants were asked to log in, to complete the self-assessment, and to try at least one intervention. The group consists of 66 healthy people and 32 people suffering from depression. So we have a mixed group and we can compare the difference in using SelfPath between healthy and depressive people. After the first day, we asked the participants to answer relevant socio-demographic and demographic questions, as well as questions related to the participants' experiences with digital technologies. Depression symptoms were measured using the Patient Health Questionnaire 9, the PHQ-9, to verify whether the participant was suffering from depression. All participants with low PHQ-9 scores, so smaller than 10, were classified as not depressive, while the rest, PHQ-9 greater than or equal to 10, were classified into the comparison group whose members suffered from depression. Additionally, we ask also to assess the usability, the trust, the task technology fit, the attitude, and the intention to use of SelfPath. After the usage period of 5 days, we ask again the participants to assess the mentioned 5 constructs so we can monitor differences between the beginning and the end of the usage period. Now, please look at the relations between the 5 constructs. Here, you see the structural equation model as a result of the study. The evaluation of the structural model included the execution of Smart PLS under default settings with 5,000 samples, with a bootstrap of 5,000 resampling iterations, and with mean replacement of missing data. All constructs had variance inflation factor values less than 5, indicating that there was no multicollinearity problem. We have the 5 constructs in blue: the task technology fit, trust, usability, attitude, and intention to use. And we found 5 statistically significant relations between them. They are marked in red. The value in parentheses is the p-value, the result of calculating the significance of quality to success relationships using the bootstrapping approach. Usability, trust, and task technology fit have a positive influence to the attitude, because the path coefficients are positive. The results show that the usability has the biggest influence to the attitude, then the task technology fit, and trust has the lowest influence. Therefore, it is fundamentally important to place a high significance on usability when developing such therapeutic systems for people suffering from depression. As expected, the attitude has a positive influence to the intention to use. Let's take a special look at the usability. Usability was evaluated by the System Usability Scale, which consists of 10 items answered on a 5-point Likert rating scale ranging from strongly disagree to strongly agree. The System Usability Scale can provide a single score that ranges from 0 to 100, with higher scores denoting higher usability. Here, the usability is between 70 and 80, as you can see on the y-axis. Here we see the assessment of the usability at the first day, T1, and after 5 days usage, T2, and separated for healthy and depressive participants. There are interesting differences between the groups. At the beginning, the participants suffering from depression rate the usability of self-pass significantly worse than the healthy participants. However, the depressive participants give a considerably better rating after the 5 days of usage, and their evaluation even exceed that of the healthy participants. This change is not observed among the healthy participants. So, this development indicates that the depressive participants became accustomed to self-pass and to the handling of the system, but also that depressed people need more time for accustoming and for using self-pass intuitively. They require a longer period for familiarization with the system compared to the healthy participants. Our structure equation modeling proves that the usability, trust, and task technology fit constructs have a positive effect on attitude towards self-pass, and that attitude has a positive influence on intention to use. It is very important to study differences between healthy and mentally ill people in using health apps. We need to know more how to design such apps to meet the needs of the user in their individual mental situation. Thank you very much for your attention and your interest in the study.
Good evening. My name is David McMahon, and I'm here today to present to you my paper, Improving Patient Throughput by Streamlining the Surgical Care Pathway. I am a PhD student from Tralee, County Kerry, Ireland, studying in the ITT Tralee Institute of Technology. My industry partners are the Bon Secours Hospital Tralee. I'm funded by joint funded operation by LERO, which is the Irish Research Foundation, and SFI Ireland. To write my paper, I took a dual approach. It consists of theoretical, historical, and literature-based findings and evidence around all the pros and cons and influencing, negating, and statistical factors of a patient as they navigate the surgical care pathway. The surgical care pathway typically involves numerous stops a patient would navigate or traverse as they go towards their surgical procedure. Typically, these involve admissions, the pre-op ward assessments, transferring, portering to theatre suite, the operation itself, and then the recovery process. Equally, I had to have to satisfy the industry partners as well by designing, developing, and implementing a solution that would complement their current workflows of a patient inside the surgical care pathway, and also deliver a patient-centric approach, or almost a holistic model on top of a technical application. With the industry partners, to achieve my goals, I conducted several interviews. I had weekly, monthly meetings with stakeholders. I shadowed all the current processes. I had numerous meetings with staff on the ground, nurses, doctors, porters. I got to know how they worked, what the system was. I then went about my task by designing a work breakdown structure of what had to be done. And then I implemented an SDLC using the spiral model and a bit of a hybrid of the waterfall model once components were finalized. The spiral model worked because I had to rapid prototype and show it to certain stakeholders at different times. The hospital environment doesn't necessarily allow for key stakeholders to be available at all times, so it wasn't practical to adopt an agile approach either, because that would have blown funding out of the water as well. So the best thing to do would have been a prototype model, and that's what I implemented. And then finally, the piloting. From a patient care pathway navigation communication system perspective, in the literature sense, I conducted an extensive literature review. I looked a lot at the historical and theoretical content. I looked at the core themes that were discovered. I highlighted the problem domain. I looked at possible alignments from a national and European content, and then I looked at existing solutions. To understand how we communicate, because it is a communication solution and problem, I suppose, we have to look first all the way back as far as the Egyptians and how they solved this. And they solved this by inventing a type of symbolic language called hieroglyphics. They use this to communicate, and they also wrote it up on walls, temples, everywhere, which is still seen today, studied today, to an extent used today in an academic sense anyway. So they started the whole thing off. The Greeks picked up on this and came up with this rhetoric, and this was all about the language of persuasion. So where now we have a language and we're able to educate, and we're able to speak and put that into a tangible thing and form an identity from this. You look at famous works like the Iliad and Homer and things like this. And I suppose Plato's famous speech, "We are simply animals that speak." This was further developed and advanced in Roman times, when papyrus was actually manufactured, more mass manufactured, I suppose, and people who were poor but could speak could now learn to write and actually get a job and move up in social class and standing as a result of that. Fast forward another couple of years, and we have the Rosetta Stone. And the Rosetta Stone, when it was found, was actually deciphered because it had an earlier version of Egyptian writing and a mixture of Greek, and it was the Greek hybrid that was in it that was how they actually deciphered it. And then modern technology, then fast forward, and we have multiple applications, mobile, different APIs, speech to text, signaling software, everything you could possibly want inside in your portable device. In a way, people are more borderline semi-illiterate now, but communication is far more available. It connects more people today than it ever did. There's more universal languages. Going back, to the slideshow. So what I found in the literature then, some of the key factors were communication structure inside in the hospital. Is there a hierarchy actually designing and implementing a communication platform so people can actually participate? Is the culture right? Is there going to be people accosted for communicating? Is the quality right? In other words, is the right information being shared at the right time by the right people? An interdepartmental alignment around communication and the communication and design implementation of protocols, and the information sharing and participation. So again, is the right information being shared at the right time, or the right people participating? What is the platform for this, and what is the documenting of this, and how is it stored? All these are key factors that influence positive communication structure and positive patient navigation of the surgical care pathway. Key negating factors then were the hierarchical influence. So, in other words, is the surgical team's opinion around an administrative task that influences the navigation of the surgical care pathway, bypassing the administration's input to such a way that it's causing a delay? Are the hierarchy having too much power in the chain, and in doing so, is this causing more bottlenecks in the care pathway? Outdated hospital information systems is another one. A lot of these systems tend to be multiple combinations of other systems that are impossible to query and traverse in terms of finding patient information. And there's good reason for that too, as well, to be fair, because a lot of these systems are built on older models, different forms of Windows, and the cost of migrating to the newer application is quite expensive, you know. The use of conventional forms of communication, so like things like pagers, things like pieces of paper, things like fax machines, stuff like this, wired phone calls, and the phone's constantly polling, is the person here, they're not, where are they, they're down here, word of mouth, things like this. You know, granted, they do have their positive things as well, but in general, modern communication can provide more visibility, more traceability, more accountability, and, you know, faster to use. Patient handover as well is a major one. When the patient has been handed over, the visibility for the successional services who will be working with the patient in the care pathway, have the visibility of this. Patient security and confidentiality, GDPR, as much as it is a good thing, it forces developers, it forces people to put an extra layer on their information sharing, on which can cause a delay, which sometimes can't be policed properly. It seems to be getting bigger in terms of performing queries on databases to find people where they are. You have to look at things like purpose limitation, which is one of the things I built in. So every app per role should only have visibility of certain tasks. So for instance, a nursing application may have a different view than the portering application, than the patient escort application, or the, let's say, the ward view application. It's on a need-to-know basis, but still with enough information for the successional task and the visibility of the patient status for them to traverse in an efficient manner. National funding then, I suppose, you know, in Ireland with COVID, a lot of funding is going to be projected towards that, as opposed to ICT solutions, which is probably what we need. There has been an increase of just over, I think it's 3% in the funding, in terms of us aligning at a European context with the funding for that. But a lot of these pilots don't end up being rolled out fully. Or, you know, there's big talk about the Sláinte Care and the National Health Plan coming together, service plan in terms of delivering different solutions, e-scribing, generic assessment sheets, generic digital charts, things like this. And that's all positive stuff, and it needs to happen. And from a European and American perspective, it's pretty much, you know, in the same boat, but they tend to be driving more software solutions and obviously have, you know, larger funding as well. And there are, you know, there's loads of different solutions, mobile, digital whiteboards, integrated sharing apps, mobile applications on wheels, desktops on wheels, identification trends such as QR coding, stuff like this. So the solution that I set about to create was going to be portable, easy to use, in terms of very simple buttons, not convoluted text fields, everything drop down, very easy to use, uniformed as well, so you knew you were on the application in terms of the color coding scheming. Assistive complementary technology, one screen leads into the next, it's very easy to use, non-intrusive to existing processes or patient privacy. I suppose the idea was to scan the patient wristband, and inside that there's the QR code. But that could also be placed on the patient chart. The chart goes everywhere with the patient, so it's not intrusive in that sense. And it's one quick scan and you know where they are then. Secure and GDPR compliant, as I mentioned earlier. It uses, the data is secure in its deposit, and the GDPR is withheld down to purpose limitation as well. And additionally, delete functions for anyone who's signing up to the pilot. They can get out of that at any given time as well. And it's robust and scalable as well. It can be rolled out across multiple satellite hospitals as well. It's fit for purpose. The overall architecture, so it uses the Power Apps framework, which is kind of Microsoft's answer to mobile Android development, which takes away a lot of the overhead of the front end development, but you still have to develop, your back end and your server layer logic, and a lot of the front end logic as well. To be fair, the way it works is the apps are downloaded from the Microsoft servers, they're coded, that then basically is traversed through this Azure cloud bus, which doesn't store, it only traverses the data. It points to an on-premise gateway, which basically is an app server, which then points to the server inside in the hospital. So it's typical kind of app server pointing, but the traversal with the Azure bus is good because it's an AMPQ 1.0 protocol as opposed to typically a HL7 protocol. So what it kind of does is it's constant listening to a stream. It's secure and certified with SOAP at both ends, client and server, over REST. So you're always going to get the data if for some reason there's a plug in the connector. And this is an example of how it would work. So the left little column there, which says log in every morning. So you'd log in with the QR code. Dependent on your QR code, that would open up a specific app. Then step 1, you'd scan the patient. Step 2, select the bed or the ward. Step 3, select the consultant. Step 4, patient ready for transfer. So this is an example of the admissions application. And as they're admitted, they can be sent to 3 different things. They're either ready to go, which someone comes in, collects them, scans them into their bed, or they may have to go for an X-ray, or they may have to go for blood tests, stuff like this. So there's a lot of the idiosyncrasies of the work has been covered in the actual applications as well. This is the top 2 ones are an example of the little mobile app, and then the kind of ones where you have all the beds laid out, that's the ward view, and there's like a traffic light system. So the first one on the right with the green box, that means someone has been parked in that bay. The amber light means that they've had an assessment carried out. Typically there's 3 assessments. There's your nurse, there's your medical, and your anesthetic assessment. Once they're complete, it goes green. So people who are coming in the morning, they can click on a button, see what patient is there, where they are in the assessment process, and if they're ready to be called for surgery. The top left one is if you were clicking in that bay there, what would happen. The other screens here with the pie chart, this is actually an application that's in the operating theatre. So the way it works is all the patients are scanned up until the point where the previous slide where they go green. And then what happens is instead of the wired phone and the conventional form of communication, a message is broadcast up to the theatre, which you can see that's the middle left slide with the big tick that this patient is ready to be called for surgery. There's additional views of this as well, like you can go for the pie chart view of this happening if you want, and then you click call for surgery. And you kind of have like a stock exchange view here as well, which dynamically adds more patients onto it as you go with the different assessments and data. And the whole point of this is that there's no more calling up to the ward and ringing around. As the processes are completed, the patient is now available to be called. And the theatre then has full autonomy off the working list, who they want to call and why. And the list really isn't really captured because there can be several reasons why someone needs to be called before another person, but there's prioritizing functionality in the assessments using the mobile apps as well. So what this does in terms of results, high-level results, so we've an 80% increase in task visibility across the board, including successional tasks, tasks completed. So we're aligning the departments through the application as well. There's a 60% increase in the verification processes. So a lot of these processes, no one was signing off on them. No one was saying they were completed. 80% increase in proactive communication. So the interlinking again of the wards with the different messaging systems, which brings everyone together. So the current capture versus the old capture is just on display here. So for instance, we had a different scenario. A patient is admitted to the hospital day of surgery. So the stakeholders, receiving ward, operating theatre, and the patient escort. So a big thing that was happening was patients were being admitted, but the ward wasn't really aware if their patients were in or not. So they wanted to come in the morning, get into the ward, have a look on the screen and say, oh, look, my patient is here. Excellent, they're admitted. Now I can go down and assess, or what's the story, who's coming next. So the process capture all these things. The manual system, which was our older model, basically the admitted time was captured, but all the other stuff was not being captured. You know, the location, were they even admitted? You know, it was just the time, but they had no visibility going up to the ward and that. So there was numerous processes that weren't being captured that now there is. And overall then the process, so this is from admissions to patient calling time. So comparing the manual time to our own time. For the admissions process, I suppose, you know, looking at linear regression, they're quite close here in the system, to be fair, and that's fine because with the actual pre-op process, what I found in terms of the assessments was that there wasn't a whole pile of change in the processes yet. So they're going to be tight numbers in that sense. You know, and there is a bit of an argument there that maybe once the technology is implemented continuously, that there will be more positive results in that factor. Now, it did improve in certain areas, but, you know, to be fair, I would say, you know, the pre-op process in terms of the assessments area seems to be something that they need to work on a lot more. You know, but it's just about getting used to the system and seeing what happens there. And in the end of the day, the most important thing is process change. And if the technology can influence that, that's fantastic. But you're the best technology in the world, and if you're using the same processes, you're going to get results like this. There was a bit of a difference in the surgery call to theatre delivery, probably a lot more. And, you know, that was just down to the way the messaging was being sent, the availability of the messages, the idea that, you know, not necessarily a big brother on the clock sort of a thing, but it was just easier for them to communicate and deliver patients. They were able to see who was, I suppose, in a way queued up, and they were able to be part of the communication going up to the wards, to verifying and up and down. And a big problem with this would be that a patient would be delivered to the holding bay and the theatre reporters would not know when to come down and collect the patient. However, they'd be going in and out of different surgeries, seeing is the patient available. Whereas now, once they were called and they were delivered, they would also get a message to verify patient is ready to be collected in the ward. So there was a much bigger difference there in terms of the manual time versus the pilot time, you know. You know, so there's better capture. A lot of the time as well with the manual times, sometimes the entries could be after the fact as well. So you kind of have to go off averages as well, you know, and that can be understood as well. They didn't really have a good system to implement the results. So now they have two. But overall, when you balance it up, the system was a lot faster. So that ends my presentation. I will happily take any questions, and thank you.
Connect. With this research, we propose blockchain and self-sovereign and identity-empowered, privacy-preserving digital contract tracing platform. So we mainly propose this platform for COVID-19 outbreak control situation, but it can be used in any pandemic scenario to contact tracing and activity tracing. So these are the authors of this work. So I am the presenting author, Iranga Bandara. First, I will give a bit introduction about me. I'm Eranga Bandara, working as a senior project scientist at VMAS, Virginia, USA. I'm involved with various projects on blockchain, distributed systems, cybersecurity, machine learning, federated machine learning kind of areas. So actually our main goal of doing research is we always try to do research and build production grade applications based on these researchers. So we just not satisfied only having a publication, we always trying to make a production grade application, so based on our researchers. So Connect is one such platform. We have built various such platforms. So we built blockchain platforms, federated learning platforms, distributed applications, mobile applications, so such applications. So all are based on the our researchers. I'm available on Twitter, so this is my Twitter username. If want, we can contact via Twitter as well. Okay, let's look at some background information about Connect platform and how we propose contact tracing via this Connect platform. it's a privacy-preserving contact tracing platform which built with blockchain and self-sovereign identity. Connect mainly target for COVID-19 contact tracing, but it can be used for any pandemic scenario to contact tracing in a privacy-preserving manner. So our main goal is guarantee the privacy of the data, users' data, while doing the contact tracing. So for this work, we have collaborated with the Centera Hospital chain, Virginia, USA. So we built production-ready platform of Connect with collaborating with Centera. Okay, so currently there are various contact tracing platforms available. Various providers propose different contact tracing solutions. So the main concerns we need to satisfy of the contact tracing is the contact tracing platform should guarantee the privacy concerns of both potential patients and the people they could come in contact. So, but most of the existing contact tracing platform lack of these privacy features. So they suffer with data centralization, privacy concerns, and location tracking kind of concerns. So the main thing here is the centralization of the user personal data in a cloud environment can be vulnerable to various attacks. So we shouldn't store all the personal data and contact tracing data in a cloud based centralized system. So with this research, we propose blockchain and self-sovereign identity empowered decentralized contract tracing platform to address the privacy concerns on the centralized contract tracing platforms. Actually, most of the existing contract tracing platform built with centralized architecture. Instead, we try and use blockchain and self-sovereign identity empowered decentralized architecture for the contact tracing. So connect self-sovereign identity-based ID wallet, encodes users' digital identities, and activity trace data on the permission blockchain platform, and verify user SSI proofs. Actually, we propose mobile wallet application for the users. So and admin also we provide 2 mobile wallet applications. So by using these mobile applications, users can record their identity information as well as contact tracing information on privacy preserving manner. So all the actual information, identity and contact tracing information, so activity tracing information stored on the user's physical mobile wallet. The proof of the data will be stored on the permission blockchain. So it won't reveal the permission in private information of the users. Okay, so user identity information include personal information, images, ID information, kind of things. The user activities will provide information such as places, travel and dispatch updates information, location, time, etc. So in here, the activity trace record can be leveraged to identify the suspected patient and notify the local community in the real-time manner. So all the data record which correspond to the activities, so activity trace data is used to identify the suspected patients which contact with the COVID-19 and notify to the local community. Okay, so let's look at the Connect architecture, how we have built the Connect platform. So this is the high-level architecture of the Connect platform. So we have 4 major layers. So distributed ledger, DID communication layer, credentialing layer, and activity trace layer. So distributed ledger is the basically blockchain-based storage which store all the users' DID proofs, actually that identity proof as well as activity trace proofs. So DID communication layer, so it used to handle the peer-to-peer communication. Actually, we provide 2 type of mobile wallet applications. So Connect mobile wallet application for the users, so Trace mobile wallet application for the admin authorities. So actually that credential owners are the Connect users, so credential verifiers are the Trace users. Basically Connect credential owners capture their all the personal information and in their mobile wallet application, so and stored on their local mobile wallet. So then credential verifiers can verify these identities by directly fetching those information from the users Connect mobile wallet. In that case, peer-to-peer communication handled with the DID communication layer. So there's a credentialing layer, actually that credentialing capturing and credentialing verification happen in the credentialing layer. So then activity trace layer, all the activity trace records tracked on the activity tracing layer. Okay, so let's look at each and every layers with more information. So first, distributed ledger. So distributed ledger is the blockchain based peer-to-peer storage system used in the Connect platform. All users crypto artifacts we identify as a DIDs, decentralized identities, and proof of the active trace records are stored in the distributed ledger. So in here, the blockchain can be deployed among multiple organizations such as government organizations, hospitals, airports, custom officers, banks, this kind of organization. So each organization in the network can run their own blockchain node. These nodes connected as a ring cluster. So these how it look like. So there will be multiple nodes. So each node there will be admin authority in there, admin officers basically. For instance, bank. So there will be bank teller would be the admin person. So in here there's another PS type called users. Users will have the connect mobile wallet. So admin will have the trace mobile wallet. So basically users will capture all the informations via personal information. So via this connect mobile app. So then admins will verify those information and do the contact tracing as well via the trace mobile wallet. So then DID communication layer. So that's the next layer. As mentioned previously, two type of users, credential owners. Basically, they provide the connect mobile wallet. Credential verifiers are the admin authorities. So they will give a trace mobile wallet. So DID communication used to exchange the actual credential information. So basically user images, numbers, and etc. between users to verifiers mobile wallet. So these exchange happen via the peer-to-peer channel. So actually credential verification, we need to exchange all the actual credential information we stored on the user's connect mobile wallet. So then there's a peer-to-peer communication between users mobile wallet and the admin's trace mobile wallet. This exchange happen via DID communication layer. So then credentialing layer. So basically credential owner registers their DID proofs. Basically they capture the information and generate a DID proof of this information and saved on the blockchain. So and enrolled to the connect platform. So then admins, basically credential verifiers, verify these DID proofs via trace mobile wallet. So then credential registration verification happened in the credentialing layer. So basically different entities in the platform, users, admin, create and exchange credential for verification via the credentialing layer. Then active trace layer. So basically all use active trace data in the connect platform are stored in the permission blockchain ledger based on self-driving approach. So basically actually that all the active trace data also stored on user's physical mobile wallet. So the proof of this data will be stored on the blockchain as a self-sovereign identity proof. So for instance, when a user goes to a specific place, airport, bank, hospital, or any office, so the admin officer there can verify the identity of the user and create an active trace record. So in the blockchain, so basically proof will be recorded on the blockchain. Actual active trace record will be stored on the user's connect mobile wallet. So then admin also can fetch this active trace record from the blockchain as well as from the connect into the user's connect mobile wallet and verify them. So all the active tracing functions handle with the active trace layer. Okay, so connect functionality. So let's look at some scenario and discuss about the connect functionality. So consider some scenario where blockchain network is deployed at airport, hospital network, government bank, and IT office. So then admin officer at each organization so install the trace mobile wallet app. So assume a user comes from overseas and when he comes to the airport, he install the connect mobile app and register in the connect platform. So that's the basic scenario. So user will have the connect mobile wallet when he enter into the airport. So he register his identity and enroll to the connect platform. Okay, so there's a first step is identity registration. Basically, it involves the user and connect mobile wallet. So this is the identity registration feature on the connect mobile wallet. It will capture all the personal information, image, and signature also can be captured. And once captured, it saves this information on user's personal mobile wallet. It won't upload this information to any place. So once when registering, it will generate a public private key pair for this mobile wallet. So private key will be stored on the key store on the mobile wallet, and we'll generate a DID. It's called decentralized identity based on the public key of this mobile wallet. So that DID will be embedded to the QR code of this mobile wallet application. So then user can show this QR code at any place in the connect network. So to prove his identity. So this is the registration work. So basically how that DID upload, this is how DID upload or registration work with the blockchain. So it generates the DID. So this is the DID format, DID connect. This is the BS58 hash of the public key. So it will be uploaded to the blockchain. So this is the example DID record saved on the blockchain. You can see that it won't save any personal information or anything, just a DID. So that's the thing. Okay, so then identity verification. Actually, that user registered. So in first time, user need to verify his identity by using authorized person in any network. For instance, in that case, user comes to the airport. The identity verification can be done with the airport. It can be done with any place, maybe bank or any organization in the network. So basically that in that case, user comes from the airport, user shows the QR code to the custom officer or any officer in the airport or any other place. So then officer will scan this QR code via Trace mobile wallet and fetch the user's actual identity information via directly connected to the Connect mobile wallet application. This is the place where peer-to-peer communication happens. So then it will display all these information. In first time using, so user need to get the approval for this identity. That means it's a kind of vetting process. In that case, user need to show this QR code along with his physical ID. It could be passport, national ID card or any ID card which can prove the user's identity. So then what officer do is, officer compares the actual information he saved on the Connect wallet against the physical ID. If details are matched, officer will approve that identity. So that's the identity verification process. After verified or approved the identity, user can use this identity to any other place to prove his identity. So just showing the QR code. So then it can trace the activity records as well. So that's how identity verification works. So this is basically how it works. User with Connect app shows the QR code to the officer. So then officer scan the QR code. So then it connect to the blockchain and verify the DID proof. So then blockchain will verify the DID proof. Then it directly contact with the user's Connect app and fetch the actual ID information from the Connect mobile wallet and display. So that's how it works. So then activity tracing. So let's see how activity tracing works. So basically after identity verified by the admin, so user can go to any bank or state office, and when going to this office, so he can just show this identity wallet QR code to prove his identity. So in that each point, user shows his identity QR code in the wallet to the admin officer. Then admin officer scans the identity and verify it. So when verification, it automatically creates an active trace record proof in the blockchain. Actually, it will be create active trace record. So active trace record contains information about user identity, basically its DID, time, location. So this kind of information. So actually, the actual information, this information will be stored on the user's Connect mobile wallet, or the proof will be stored on the blockchain. By using this active trace information, we do the contact tracing. Okay, so when creating active trace record, so actual trace record will be stored on the Connect mobile wallet with SSI approach. Proof will be uploaded to the record in the blockchain. So anytime admin officer can view the user's active trace records by directly fetching them from the user's mobile wallet. When user goes to a specific place, when showing the QR code, it trace mobile wallet has a feature to directly fetch the ID information as well as active trace information of the user and display it. So these are the active trace information. So dispatch airport, verified at BOC, renewals, all the active trace data will be stored on here. By using this information, so admin officer, anyone can identify what are the places he recently traveled. So in here, that this is how it works. So user Connect app, so show the QR code in the officer. So same as the previous scenario, request blockchain to verify the DID. So then directly fetch the identity information. So once verified, so it create active trace proof. So it saved on the proof on the blockchain, and actual active trace record, so basically location, time and everything will be saved on the user's Connect mobile wallet. Okay. So then let's look at how we use this information with the COVID-19 contact tracing. In here, that assume some point a user who registered in the Connect platform diagnosed as a COVID-19 infected person. So in that case, maybe user goes to the medical center. Maybe in that case, so he shows the QR code, and you know that in medical office at the hospital can report patient diagnosis information to the Connect platform via the Trace mobile wallet. So we provide the feature to medical officer or any officer to add the diagnosis information, and also user can self-report the diagnosis information via the Connect wallet as well. So we provide a feature to self-report the diagnosis information. So this diagnosis information will be also stored in the blockchain as a self-sovereign identity proof. Okay, so actually, once COVID-19 case is reported into the Connect platform, the Connect platform can identify all the places where the patient has visited during last 14 days by using activity trace proof data on the blockchain and the user's mobile wallet. So by using this information, so proof on the blockchain, actual data on the user's mobile wallet, so Connect platform identify all the places he visited during the last 14 days. So this active trace data contains information about the user's identity, time, location that diagnosed patient has visited. So based on this active trace information, it can identify the other users who have been in these spaces at the same time with the COVID-19 infected person. So then Connect platform can send the notification to these users mentioning that there is a risk of getting contact with the COVID-19 infected person. So this active trace approach won't reveal any personal information of the users. It deals with only DID proofs. Actual information will be stored on the user's physical mobile wallet application. So that's how contact tracing works. So this is the way it works. So user diagnosis, so it report. So then blockchain save the diagnosis information proof. So find the active trace of the user in last 14 days. So find the places and times he have been in by using this activity trace data. So then find other users who have been in these places at the same time. So then notify to these people. So that's how active tracing works. So then we extend the other functionality as we build some COVID-19 hotspot information. For instance, so based on the active trace information on the blockchain, Connect identifies COVID-19 hotspots. The hotspot information will be shown in a map view on the Connect mobile wallet application. Hotspot critical level is decided based on the infected people count visited to a specific place. So this is how it's look like. So there will be red zone and green zone. Red zone means actually that considerable number of people visited, COVID-19 infected people visited to this place. So green zone means it's a safe place. So in that case, so this critical level will be decided based on the number of people who have visited to this place. All the data, all the decisions will be taken based on the active trace data. So in here that for instance this information will be shown in the mobile wallet. For instance, if I'm going to some place, I can just show search that place and identify whether it's a red zone or green zone. So then I can decide whether I'm going to that place or not. So that's another additional feature we are providing. Okay, finally Connect implementation. So we have done a production ready version of the Connect platform with collaborating with the Centera Hospital chain, Virginia, USA. So this is the high level architecture of this platform. So we built this platform on top of permission blockchain. We have used Rahasak blockchain to build this system. Rahasak is another work production ready blockchain platform that we have built. So based on our another research. So we built this platform as a microservices based architecture. So there are, you can see there are different services on the out service. So notification service, monitoring services, so storage services, etc. So all the inter-service communications happen via Kafka, Apache Kafka. So most of the services built with Scala language. So and some of the services built with Golang. So we have provided two mobile wallet applications. So both for Android and iOS. So there are two type of mobile applications, Connect and Trace. Both support for Android and iOS. So that's the high level view of the architecture. So platform built with microservices architecture. Services are deployed using Docker and Kubernetes container orchestration system. So we build this platform as a microservice basically. So microservices communication will implement with Apache Kafka by using reactive stream based approach. So all the blockchain functions implement with the Rahasak blockchain. So that's another blockchain platform that we have built. So it's a production ready blockchain which mainly targeted in the big data IoT kind of scalable enterprise level application scenarios. So monitoring services implemented the Prometheus, Grafana and Kibana kind of monitoring services. So I have mentioned that there's a peer-to-peer communication between mobile wallets. That communication implemented with the Firebase notification messaging service. So and we have used Apache Cassandra based off-chain storage. All the analytical information will be stored on there. For the authentication, so and authorization, we have used JWT, JSON Web Token based auth service. So that's the basically implementation details. So we have built a production ready version of this platform. Okay. Yes, so that's it from my side. So thank you very much for your time. So if you have any questions, we can discuss them now. Okay, thank you very much.
Good day, ladies and gentlemen, and apologies for not being able to be present at this webinar, seminar on ethical assurance. My name is Ali Hessami, and I'm the Vice Chair and the Process Architect for IEEE Ethics Certification Program for Autonomous and Intelligent Systems. I would like to take you through some aspects of IEEE Standard Association's initiative that's aimed at autonomous and intelligent systems certification on the ethical dimension. They talk under the banner of ethical assurance for decision-making and algorithmic systems. I would outline the general context for the talk, refer to some IEEE standards, and then focus on the ethics certification program in this presentation. If you look at technology ethics context, we have a number of headings and focus areas that you can see here. Generally, there are concerns about autonomous decision-making and algorithmic learning systems when it comes to bias, to matters of transparency and explainability, to matters of accountability and responsibility, to issues of ethical privacy, even though we've got a legal privacy dimension covered in GDPR, and then the old-fashioned friends of safety and security dimensions. IEEE has a global initiative that under which on autonomous and intelligent systems, and under that there are a number of components and work streams, one of which is ethically aligned design, or EAD, which is around 3 pillars of human values and human rights, political self-determination and agency, and technical dependability, that are split into 8 principles that are detailed in our publication called Ethically Aligned Design First Edition, that was published around March 2019. That's available from IEEE as a free download, so feel free to go and take a copy. This is an extensive coverage of ethics in technology, from matters of human rights to transparency, accountability, data agency, etc. And it covers these 8 areas of so-called principles that are significant to technological trust and dependability. The second dimension is that of IEEE series of standards that are focused on ethics and technology ethics. The core standard is called P7000 or IEEE 7000, and its purpose is to actually offer a model process for addressing ethical concerns during system design. It covers kind of a generic mission analysis for any type of product or service, then identifies values that are relevant to that context of application, and then offers a risk-based design practice that protects the human values. There are 14 standards in the 7000 series that you can see. Only one of those have already been published on Wellbeing metrics, the 7010, and the others are in various stages of development. They collectively cover technology ethics dimension of a standardization in IEEE SA. The third initiative that I like to focus on in this talk is about ethics certification. Around 2018, IEEE initiated the ethics certification program for autonomous and intelligent systems that we refer to as ECPAS program. This program is aimed at developing criteria and certification for matters of transparency, accountability, and reduction in algorithmic bias in autonomous and intelligent systems. We had the honor and the privilege of running this program. And we started by forming 3 expert groups through some form of self-declaration by experts in terms of their competence related to ethical accountability, bias, or transparency, and got started around 2019 on this work. The idea was to also develop some terms of reference for each one of these 3 expert groups, because we were developing 3 dependent criteria for ethical assurance. So we developed terms of reference for each one of these groups, and the remit was to develop what we call ethical foundational requirements for transparency, accountability, and reduction in bias, and then translate those into some specific parameters to prepare them for certification and conformity assessment. Here's an outline of what terms of reference looks like. It was intended to purely clarify for each one of our expert groups what the mission was, what the remit was, what was the scope, what was included, and what was outside the scope of the work, for clarity and objectivity of the work. Going towards the work that was started by around June 2019 in earnest, we focused on accountability, which largely tackles matters relevant to autonomous decision-making and algorithmic learning systems, insofar as who are the responsible people and what are the critical decisions, and in a sense, who are the so-called can holders. We adopted a model-based approach rather than a narrative textual approach to development of the criteria. Here is an illustration of the model that was used for ethical accountability for AIS, Autonomous Intelligence Systems. And the models were basically the foundation of a large number of online workshops that led to completion of these models. And then from the models, we developed the criteria. Then we did a similar exercise for ethics transparency. This is about openness, about disclosure, about accessibility of records and context and design concepts, etc. It applies both to data sets that are used in autonomous intelligence system as well as to algorithms. And similarly, we used a model-based approach for capturing the expert panel's concepts and ideas about ethical transparency. And these models were later then so-called harvested for concepts that constitute our ethical criteria for certification. And finally, algorithmic bias that arises from errors or potentially sources such as algorithms or data sets in autonomous decision-making and algorithmic learning systems. And the concern is that it can lead to unfair outcomes, and it can arise from design or classification or data collection and even wrong context of application. Similarly to the other 2 work streams during our work on development in 2019, we adopted a model-based approach to capturing the principal concepts for algorithmic bias that were later translated into a series of criteria. Just as a matter of elaboration, the models that you can see are bipolar. That is, they look for threats and opportunities in the sense that we identify both the parameters and factors that contribute to algorithmic bias, as well as those that actually detract from acceptable levels of algorithmic bias. So we do have positive and negative flows into our models. That's a major difference from traditional structure, where we basically look at the essential components, but never at risk factors alongside these. Our approach, therefore, in under ECPAS program, came up with three large models or schemas, which were harvested for deriving ethical foundational requirements, and we added other parameters to these foundational requirements, including guidelines which sets of these requirements apply to specific stakeholders such as developers, integrators, operators, even regulators. We have three tiers of requirements for different risk profiles of products and services. The lowest level is called baseline. Medium risk level is called compliant, and the highest risk level is called critical. So the entirety of criteria is not applied to every product and service. There is a pre-assessment activity where we profile the product and identify which set of criteria are applicable to that risk profile. This is not very different to some emerging regulatory approach to risk in Europe, that in the middle, other than those products and services which pose unacceptable risk and shouldn't be tried, and those which are a negligible risk and do not require any expectations and controls, there are generally three levels that we have also got. And obviously the level of protection that's required by any design and any system, including ethicality, is proportionate to these levels. Hence, our criteria are split into three risk levels. Here's an illustration of our system where we have got the ethical foundational requirements. In this left-hand column, we have a concept from the graphical model, the so-called schema, say for transparency. This concept is translated into ethical foundational requirement. In this column, we declare whether the requirement is normative or instructive, or informative. This column indicates whether the requirement is applicable to low index risk, medium impact risk, or high impact risk, what level of risk of product or service the requirement is applicable to. And then we identify the stakeholders, and we even spell out what are exactly the acceptable type of evidence that are expected for the level for that particular requirement, and how should that evidence be evaluated. By the time we finished towards the end of 2019 in the ECPAS program, we captured the outcomes in a number of internal reports. These are not, unfortunately, available in the public domain yet. And each one of the work streams, transparency, ethical transparency, accountability, and bias, have their own report. And there is also a separate report for all the ethical criteria and associated measures such as normative, informative, stakeholder, and risk level. The current status of the work is that we have got the work completed on those three areas, where we are starting with new piloting and tailoring projects at the moment. I'll quickly elaborate on some of those. Because our internal reports are not available in the marketplace or in the open space, we have got some summary and overview documents. So if anyone is interested in understanding the overview of what our criteria are about, I'm happy to share some of those with you. We also developed a kind of a inquiry and a so-called response process For our pilot projects, we are currently reviewing, applying our criteria to a number of projects. And we also have devised a kind of a standardized format for case for ethicality in the context of transparency or accountability. So deliverables of any evaluation process into assessment and certification is standardized in the context of case for ethics. And those of you who are familiar with system safety, it's fairly identical to a safety case. We have also devised a training program which is used at 3 levels to train executives, engineers, as well as trainers and advisors and consultants. We currently have a number of projects since early 2020. One pilot project is actually applying our criteria to a public service to evaluate its practical implementation. We are developing a 4th suite of criteria on ethical privacy at the moment. We did an extensive work on ethical parameters associated with COVID-related contact or proximity tracing applications as a fast-track project as a response to the crisis associated with the pandemic. And we're also conducting a study of ethics in the context of financial services products. Just to refer to the contact tracing, that was an initiative that we started because of our concern about lack of societal adoption of applications and products. We use similar technique by graphical knowledge capture and criteria development. So this ended up being roughly 30 sessions starting in May 2020 as completely out of context, and it wasn't part of our program, but just felt it was the right thing to do to try and assist the duty holders with transparency, accountability, and privacy matters that would help develop public confidence in contact tracing solutions that are developed in every country as we speak. We split the program into 2 phases. Phase 1, we developed 55 criteria for privacy, transparency, and accountability of contact tracing as parameters and hygiene factors to improve public trust, and published those in July. We continued with the work and finished that last month, and we have now completed the entire set of 95 ethical criteria that underpins the integrity and trustworthiness of contact tracing. These reports are available as Creative Commons globally, and you're all welcome to apply and access these reports. They were produced, as I said, at a very high pace, and now we have completed the task and published it. And we recently also had a webinar where we described the essence of the work, and we are happy to repeat these webinars as the global demand dictates. We have got a number of parameters associated with contact tracing that we have captured in our report. The whole idea is to actually enhance public confidence in the application through ethical parameters rather than only pure concern for technology. So 2 phases of fast track work were completed by October, and the webinar took place only a couple of weeks ago on the 14th of October, and we are more than happy to repeat as per demand. Going back to concerns over ethics certification. Why does that matter today largely, I suppose, because there are huge uncertainties in autonomous and intelligent systems, and we need to, being new technologies, we need to have a precautionary approach. These technologies, because of autonomy and removal of human agent from the loop, tend to be somewhat entangling humanity with respect to rights and values, because there is no longer dealing with the human agent. So that's the second reason why ethics is so important in the context of, and the third reason, frankly, is that most organizations wish to go beyond corporate social responsibility and engage with responsible innovation. And in that respect, if there are independent criteria that can be checked, audited, and even certified by a third-party, independent third party, that enhances their chances of claim about ethicality. The interesting thing is that independent suite of ethical criteria being sort of verified and applied can identify strengths and weaknesses and shortfalls in the approach and in the technology, and in a sense can help with plugging the gaps and enhancing the integrity through independent scrutiny. Our ECPAS program provides these mechanisms. It's focused on ethical parameters that enhance confidence that the product or service that is being analyzed has not got unacceptable societal outcomes and potential harm for the society. Therefore, the ethical assurance and certification in reality is a basis for enhancing public and civil society's trust in products and services, very much like standards in other domains. But in this context, we are dealing with matters of ethics, which are very hard to quantify, hence our approach to development of ethical criteria. I thank you for your attention and time. There are contact details here, and I welcome any inquiries about our work or access to the reports that I have referred to here, and wish you a very enjoyable webinar today. Thank you.
Hello everyone. My name is Han Yu, an author of this paper. Thanks for having me today, and I will talk about the paper, Forecasting Health and Well-Being for Shift Workers using Job Role-Based Deep Neural Network. First, I will give a quick introduction. Let's take a look at the group of shift workers. So shift workers are important contributors to our society, and our daily lives are all highly relied on shift workers. They can come from different backgrounds of life, such as hospital staff, hotel employees, firefighters, or even some on-call software engineers, I guess. I mean, shift workers are really a huge group. Around 20% of worldwide employees are actually involved in shift working, more or less. But such a group faces some higher risks in health and well-being problems than normal work shift people. For example, shift workers are more likely in a sleep disorder, in insomnia situation, and they may have some lower alertness in working, which may lead them to errors and more even accidents. Moreover, they have risks in pathological disorders and some bad mental health situations. So how to help shift workers before their well-being status become worse could really make their life better. This figure shows the well-being status of shift workers. As indicated, their status may go down with time. So if the status dropped to a particular point, some serious outcomes may happen, such as emotion depression, or some extreme case. They may even suicide. In this case, we believe the best way to help shift workers is to provide some proper interventions when situation is still under control. So we have a critical point here, and where we want to do some intervention and make a situation better when it's getting worse. And in this work, the target for us is to find this critical point. In other words, we will need to predict shift work's future well-being and health status in advance. Let's take a quick look overview of data-driven health and well-being prediction work. First, we collected some physiological and behavioral data from sensors and users' daily questionnaires. The sensors we were using is Federated Charger 3, and we designed some questionnaires to collect data as well. After extracting some features, we built some machine learning models and get a prediction for participants' next day's health and well-being label. This is the overall framework of this paper. So let's take a look at the data set. We collected the data from a hospital in Japan. They have 14 participants with an average age of 31.4. There were around 241 days data was collected. From wearable sensors and daily questionnaires, we can extract 23 daily features, and also 5 daily health and well-being labels was also collected from the daily questionnaires, which is self-reported by participants. Those are daily features we extracted and engineered from raw data, including categories such as heart rate, daily activity, work shifts, sleep condition, and special intakes. For example, we extract the mean standard deviation value from heart rate. We also computed some advanced features like sample entropy, which leverage the heart rate's temporal features, temporal complexities. So similar method applied to steps data, and we also calculate some look precisely calculate the standard deviation across the data's precisely 3, 5, or 7 days features. Also, we recorded the work shifts and work durations. The feedback will return as some sleep durations and sleep efficiency, or even we can calculate some sleep regularity according to feedback data. Some special intakes like caffeine, alcohol, and drugs are also recorded, because we believe those features are all related to shift workers' health and well-being. When we get these features, we did some feature analysis and finding some differences between nurses and doctors. For example, the nurses' average heart rate was higher than doctors, but doctors may have a higher sleep efficiency but lower sleep regularity than nurses. We also found the overwork situation is more common among doctors compared to nurses. The collected health and well-being stages includes 5 different labels. Participants report that they are alert, happy, energy, health, and stress every day in the morning in a scale of 0 to 100. In this case, 0 means the most negative and 100 means most positive. Also, we did some analysis among those labels. We found some differences between nurses and doctors even in labels. For example, this figure shows the distributions of nurses and doctors in terms of alertness in the morning. We can find that they are actually 2 different distributions. And we found that the average alertness is higher in doctors than nurses. Besides, we also found that actually all labels are correlated. For example, if one participant think this participant is happy in the morning, typically these participants will also feel energetic and less stressed. These findings reminded me, oh, we really need to consider both the differences between nurses and doctors, as well as we need to consider the correlations among labels in modeling. Let's look into method part. This figure shows the model we proposed. The inputted features was first go through a feature-wise CNN layer and get some embedded features. Then we design a multitask and multi-label model structures to do the rest of the prediction work. I will explain in more details in the following slides. First, after feature engineering, we extract some features already, but we may have a lot of redundancy information as well. For example, we analyze the standard deviation of heart rate and step counts across the preprocessing 3, 5, 7 days. Those features definitely show some overlap information because it's accounting for the preprocessing days and it's having overlap. So maybe we should find a way to embed them into a higher level feature so we can get some stronger representations for the models. In this work, we are using a convolutional kernel, and using the convolutional kernel, we can extract the feature, we can embed the features to some high-level features. And this process will automatically computed by our machine. After obtaining the high-level features, we would like to build a multitask learning structure as the figure shows. First, some hidden layers would take care of both nurses and doctors' data. Then the network would divide it into two different branches. One branch is for nurse and one branch is for doctors. We were doing this just because two different job roles share some points in common. For example, they are in the same hospital, they may have a similar routine and a similar work routine. However, as we discussed in previous sections, we already found that they have a lot of differences. In this structure, we will be able to consider both the differences and the common points between nurses and doctors in modeling. Then we would apply a multi-label output, which predict all 5 labels in the same branch. So the model could also learn correlations among all labels. Here shows the overall objective function. We can see the overall objective is first the sign up of the nurses and the doctors. Then for each nurse and doctors, we have all 5 labels. We have all 5 labels predictions laws as well. So this structures counts up 2 different job roles together and also 5 labels together. Next, I will show some experiments and the results. To evaluate the model, we designed some experiment to do the performance comparison. We first calculated the model performance of our proposed model and some baseline models such as support vector machine, random forest, and even neural networks with only hidden layers. Also, we compared the performance with some control group models, such as only divided into 2 different branches without a multi-label, or we can consider multi-label only on dataset of nurses, doctors, or all participants without doing any multitask learning. We tested the model in doing 3 different tasks. There are 2 types of classification, including binary and 3-class classification, and also a regression. For doing the binary and 3-class classification, we divide the labels to different classes according to participant score, and we will use the F1 score and the macro F1 score to evaluate our results. For doing the regression part, we will need our model to predict the value between 0 to 100, and we will use the mean absolute value to evaluate our model's performance. As shown in the table, we found that actually our proposed model performed the best in almost all cases. For example, in a regression tasks, or proposed model is the only best result among all tasks. Although we now getting the prediction value now, but another difficulty in this work is interpretability. Ideally, we want to provide the participants some reasonable explains along with their health and well-being prediction results. So we can look at so in this case, we look at how to analyze the feature importance in our model. First, because we leverage the random forest, such as those kind of linear model, we can extract the feature importance directly from random forest. Then we also look into the convolution kernels of embedding layer. Because we know we are doing a row-wise convolutional kernel, so each parameters in the kernel would just correspond to the feature we imported. We can simply look at the parameters in the convolutional kernel, and we can pick parameters with highest value, and we can see the corresponding features could be important. Another thing we have done is calculate the correlations between inputted features and the intermediate layers correlation. So if inputted features shows a higher correlation with the embedded features, we can see, this feature might be more important than others. So we found some important features for both the linear and or proposed multitask, multi-label neural network structures. And we also found some features such as sample entropy of heart rate, sleep duration and regularity, step counts, work shifts are important in both the linear and or proposed model. To draw a conclusion, we first collect data from the shift workers. Then we found the features differences and the label correlations through our data analysis. We design and implement work based on our finding. Finally, we try to interpret our model, and we found some important features. In the future, we will definitely continue this study and collect more data from different participants. And we will provide participants daily feedback of their predictions and well-being stages. For example, it's more like participants collect the data and submit it to a server, and we will give a prediction and provide the feedback to them according to the data they updated in timely. So, and in the future, we will also thinking about develop and evaluate other intervention systems to actually improve the shift workers' health and well-being. That's all my presentation. Thank you for listening.
My name is Ganesham Prabhu. I'll be presenting my paper, a deep learning model for exercise-based rehabilitation using multi-channel time series data from a single variable census. My presentation has introduction, proposed framework, methodology. I'll give experiment results and then I would like to conclude. Community-based or home-based exercise are approaches commonly adopted for rehabilitation. Exercise-based rehabilitation often needs to be long-term. Unfortunately, for a variety of reasons, including travel distances, organized classes not being scheduled friendly, and some people not wanting to exercise in front of others, adherence to organized programs tend to be very low. Alternatively, if people could exercise anywhere convenient to them at any time, it may act to motivate the uptake and adherence to exercise-based rehabilitation. Such an approach would be facilitated if information on the type of the exercise and amount of exercise was automatically detected in real time and summary feedback is being given to the patient, and it has been shown to be motivating factor for rehabilitating patients. Technology advances in wearable sensors have resulted in cost-effective devices capable of recording human movements effectively. Human activity recognition is an increasingly important research topic where human movements and associated activities are studied using advanced artificial intelligence algorithms, using machine learning and deep learning models applied to sensor data from wearables. In recent years, the use of a single wearable sensor has gained prominence in different areas of human activity recognition, such as day-to-day activities like jogging, running, walking, etc., gym activities, and exercise recognition, and in reputation counting. Studies have shown that elderly rehabilitation patients, almost around 68%, have indicated their interest in using a single variable based measurement devices in exercise-based rehabilitation. The increased interest in using deep learning models in the field of human activity recognition and especially exercises have resulted in various models being used for exercise recognition and repetition counting. However, it appears that no studies have used a single deep CNN model architecture using multi-channel time series data for exercise recognition as well as repetition counting. Using a single model architecture for both tasks simplifies implementation and training. This is an important consideration if the AI-based technique were ultimately to be implemented as an embedded function of the variable sensing platform. As such, this study aims to demonstrate how a single CNN model architecture can be used for automatic exercise recognition and repetition counting using multi-channel time series data obtained from a single variable sensor. This is the end-to-end pipeline framework that we adopted for two tasks, the exercise recognition task and the repetition counting task. The framework consists of data processing unit to process the input data set, two CNN models using same single deep CNN architecture, one model for each task, and output processing unit which consists of fully connected layers. We have used the Insight LME dataset, a dataset which was recently made publicly available, consisting of 11 classes of movements, with the first 10 classes corresponding to the LME exercises commonly used in exercise-based cardiovascular disease rehabilitation, and the 11th class corresponding to movements commonly observed between exercises. The dataset consists of raw time series data from a 3D accelerometer and a 3D gyroscope using a single IMU mounted on the right wrist and was collected from 76 healthy and able-bodied participants. The IMUs used in the dataset was Shimmer 3 IMU, which were lightweight variable sensors unit from the Shimmer Incorporation. Each IME used in the data collection process was calibrated using Shimmer's 9-degree of freedom calibration application, and a sampling rate of 112 Hz was used in the data capture. Exercise data were collected in two sets from the participants under constrained and unconstrained environment. 60-time series data from 3D accelerometer and 3D gyroscope were further used in the data processing. The 10 LME exercises consist of 6 upper body LMEs, bicep curls, frontal raises, lateral raises, triceps extension with right arm, pec deck, and trunk twist, and 4 lower body LMEs consist of squats, lunges, leg lateral raise, and standing bicycle crunches. So these plots are 25-second segmented time series sensor signal plot of 3D accelerometer and 3D gyroscope for the frontal raise exercise. Data processing was performed on the Insight LME dataset to have 60-time series array information with 2 target labels. So the new 60-time series array information was generated from data segmentation process using a sliding window method. So we have used a window length of 4 seconds and an overlap of 0.5 seconds in data segmentation process. And from every 4-second segment of exercise data, a 60-time series data array was formed and was computed from all the exercises. The processed data from 76 participants was divided into 3 subsets. A training set was formed with data from 46 participants. Additionally, from the remaining participants, a test set and a validation set were formed with the data from 15 participants each. The 2 class labels were also generated for the new 6-day time series array information. First target labels were used for the exercise recognition task, and the second target labels were used in the repetition counting task. The first target labels were for the exercise recognition task and were the 11 class label information of the exercise movements. However, for repetition counting task, a new binary class label was added on each 4-second segmented array data using a 50% grid method. So ground truth with the newer binary class information using grid was generated using dominant signal information for each exercise. If the dominant signal peak lay at the left half of the grid, then a label information peak was added, otherwise a label no peak was added. We designed and built a deep CNN model from scratch using same single architecture, one for exercise recognition and the other model for repetition counting. The single architecture which we used in both the model consisted of 7 2D convolution layers in addition to input layer and 2 fully connected layers and dropout layer. Number of filters used in 7 convolution layers were 16, 16, 32, 32, 64, 64 and 96 respectively. The selection of number of convolution layers and the number of filters in each layer of the CNN model architecture were arrived after the initial few trials with different configurations. Output of each convolution layer was batch normalized and a ReLU was used and then the output was taken using max pooling. The output of the 7th convolution layer was flattened and a fully connected layer was used. A dropout rate of 0.5 was used in the fully connected layer to prevent overfitting of the data. The LME exercise recognition task was an 11 class classification problem, and hence we used a fully connected output layer with a softmax activation function capable of classifying output into 11 classes. The same architecture was used as a binary classifier for the repetition counting task. We used a fully connected output layer with a sigmoid activation function here, capable of classifying binary class. The binary class label information associated with the input was used for output prediction in the fully connected output layer. This single CNN model for repetition counting works parallel to the exercise recognition task, and the predicted output are used along with the exercise time information from exercise recognition model. Finally, a counting function was used to count the total number of repetition using the transition information associated as shown in the diagram. The CNN models for both tasks were constructed using Keras API with the TensorFlow backend with the choice of optimizer function among stochastic gradient descent, ADAM, as well as RMS Prof. The best learning rate was selected by training the model over a range of 1 e to the power of minus 3 to 1 e to the power of minus 10 with a decay of 1 e to the power of minus 1. The multi-class classification model for exercise recognition was optimized using the loss functions such as categorical cross entropy and Kullback-Leibler divergence to have lower losses. However, the binary class model for repetition counting was optimized using binary cross entropy loss function. Data segmentation like sharing, resizing, flipping, rotation were not performed as the input is a time series data and it is not relevant in time series data processing. Models were trained using the training set and validated using the validation set. A model with the minimum validation loss with the best validation accuracy was selected as the optimum CNN model in both tasks and was further tested using the test set. The optimum model was evaluated for individual class performance based on statistical measures such as precision recall and F1 score in an exercise recognition task. A CNN model with ADAM optimizer having a learning rate of 1 e to the power of minus 7 and a KLD loss function was found to be the best model. The model recorded an overall training score of 96.89% and a validation score of 88.97%. For the test set, the model recorded an overall test accuracy of 95.61% and an overall F1 score measure of 96% and an overall loss of 0.128. Plots of the learning curves in terms of training and validation accuracies as well as training and validation losses are shown here, which were results of our model building. The performance of CNN model in terms of precision recall and F1 score for individual exercises are then tabulated after model building. The model recorded an overall precision of 96.52%, overall recall rate of 97.13%, and an overall F1 score of 96.8% for the upper body LMA exercises. For the lower body LMA exercises, the precision recall rate and F1 score measures were found to be 95%, 95.99%, 97.08%, and 96.5% respectively. For the repetition counting task, the binary classification model was trained and the optimal model was selected based on validation score and incorporated with an ADAM optimizer and having learning rate of 1 e to the power of minus 6. The optimum model was further tested with the test data and test data set to count the repetitions. The test data set consisted of 30 exercise data from each exercise type corresponding to 15 participants performing each exercise twice, and each exercise in 25 segments of data, participants have performed 6 to 7 repetitions. The table shows results of repetition counting for individual LMA exercises in terms of number of absolute errors. So the absolute error counts are in terms of 0, 1, 2 or more than 2 errors. The repetition counting method performed better for upper body LME exercises like bicep curl, frontal raises, lateral raise, and tricep extension with right arm, in comparison to the repetition counting of the lower body exercises. For example, as shown in the table, the upper body LME exercises, 0 errors in repetition counting were reported from 168 instances among 180 observed sets. A significant amount of error count for the upper body LME exercise was with one count error. We could achieve 100% correct counting only in the case of lateral rise exercise trials. repetition counting performance for lunges, a lower body exercise, was observed to be very poor. Performance of the model can be evaluated with a tolerance of 1 repetition count error, that's blue and yellow added together. The repetition counting from the models was within an error of plus or minus 1 repetitions in 88% of the observed exercise sets. So to conclude, in this paper we studied a deep CNN model architecture on the Insight LME dataset for automatic recognition and repetition counting in LM exercises. The dataset used was based on the data from single wishbone inertial measurement unit from the exercise used in CBD rehabilitation process. We found that the deep CNN model constructed on the time series data was an efficient model for exercise recognition as well as repetition counting in terms of accuracy measures. In addition, we demonstrated a novel method of using a single model based on multi-channel time series data for the repetition counting from all the 10 exercises. The automatic recognition and repetition counting of exercises was achieved using multi-channel time series data obtained from a single wearable sensor. We achieved an overall F1 score measure of 96% in the exercise recognition task, and the repetition counting was within an error of plus or minus 1 count among 88% of the observed exercise sets. Our study also showed that it is possible to use a single CNN model for repetition counting from all the exercises with very little loss in accuracy. Thank you very much.
Hello everyone, welcome to our presentation. Today I'm going to talk about a work we have been working on lately. It's called Bayesian Inference Federated Learning for Heart Rate Prediction. For this work, we have adopted a Bayesian inference approach to do federated learning that will preserve privacy, and this work targets at a heart rate problem, a prediction problem in particular. So first of all, a bit background on this problem we are trying to solve. So pervasive computing applications are everywhere, and they are very popular and very successful as well. If, to name a few, we have seen smart homes that's targeting maybe at elderly home care, and also smart offices. And basically, you can attach any words after smart to make a pervasive computing applications. And the success of pervasive computing probably can be attributed attributed to two factors. The first one is the advances of the hardware. We've seen more and more accurate sensors, small fine-grained sensors that can monitor what is going on underneath the physical process. And also we've also seen another element that attributes to the success, that is the advances of learning algorithms. The machine learning algorithms that make sense of this data set, that provides of hints or provides of useful information from the data set, actually is a driving force that makes pervasive computing applications so successful. However, there is a big concern about pervasive computing. That is the privacy. We all know that machine learning algorithms are built based on data. Usually we can see here we got this learning algorithm for pervasive or ubiquitous computing. Usually the data sets are collected across different platforms or different devices in a very distributed nature. Here we can see here that, for this notation, they are basically n data sources. They are collecting n at n different sites and maybe simultaneously in parallel about n subjects. And each data I here becomes a data set that measures some underlying physical process of one subject. Usually can be heart rate, physical process, or even more privacy concerned data set or features. And the objective of a machine learning algorithms is then to learn such a model that based on the pooling of all those data sets across the different, collected across different sites, to learn a model parameter to, say, do classification or regression based on the problem domain or the objectives of the learning question. So to pool the data from different individual sources to a server is a very big privacy concern here, because the transmission and storage of data across different sites will imply quite the possibility of privacy infringement. So some people might raise this concern that pervasive computing will inevitably lead to pervasive privacy infringement. That's not something that is very desirable. And federated learning, which is a branch of machine learning, is exactly technique or field of study that we can borrow and we can make use of to achieve such a privacy-preserved learning algorithm. In a nutshell, federated learning achieves the global training objective without pulling the data together. So the learning is done distributedly, and such that the model learned by federated learning in a distributed way is as good as if the data is trained on the pool data. And we can also do model customization based on the converging global model. For example, if we want to make sure the model can be customized slightly to tailor to an individual model's data set, then we can also should be able to do that as well. So there are quite lots of different benefits of federated learning. For example, privacy preserving, because we don't have to put data together. Of course, there won't be a possibility of privacy infringements at the first place. And also, we also got the benefit of saving the transmission of the data, because if we are concerning about traditional machine learning, the data has to be transmitted and stored at a central server, and the data set can be huge as well. Federated learning will save us from doing that. So what we have done here is we have proposed a Bayesian-based federated learning framework, and we also target at a wearable data set problem, that is heart rate prediction problem. And because we have adopted a Bayesian approach, there are few benefits that will be automatically inherited. Because it's a Bayesian learning, so the learning algorithm itself will be statistically sound inference procedure. And also other different irregular conditions can be automatically resolved. For example, model overfitting, because for Bayesian approach, we have to adopt a prior distribution, and the prior combining with a likelihood will automatically do that model overfitting and prevent overfitting for us. And also, imbalanced data set and numerical stability can also simultaneously achieved by adopting such a Bayesian approach. And also, for this work, we have targeting. We are targeting at a particular problem called heart rate prediction. So we are using wearable devices, data collected by wearable devices, which is a very popular IoT devices, obviously, and such a problem has very practical applications, but also has real practical values, but also provides a battleground for us to study this kind of problem. So to predict a heart rate, here we have adopted a linear model called autoregression with exogenous variables, or ARX model. So here, YT are just the time series of heart rates. So basically, we are predicting heart rates based on the historic heart rates, if we have them, and also based on conditional on some actual variables or independent variables, like, for example, speed. We usually see, we usually observe the heart rate, of course, correlates with how fast people run. And also, because it's a regression model, we also have to add a Gaussian likelihood or observation errors at the end. So the model can be succinctly written as a basically linear regression problem. Here the model parameters are the beta and also the observation noise sigma, or variance sigma squared. So first of all, we have adopted or proposed a model that's based on Bayesian inference. We call it sequential Bayesian upgrade. So diagram in a diagram, or the model can be, the learning procedure can be summarized as, here we have in the server a global model we're trying to learn at the end. So here we have adopted a sequential update procedure. Essentially, we have a model parameter phi here, and that's basically the collection of beta and sigma square. That is the prior distribution, that is a prior distribution parameter. And based on Bayesian inference procedure, we can essentially update this model parameters phi here iteratively or sequentially, one by one, across the different distributed wearable devices. So the data set or model will be learned locally through model update, and the update procedure has been listed here. So in such a way, the data set won't be will not be required to send to the server, and all the model learning are done at local level at different wearable devices or local sites. Here, the NIG means a normal inverse gamma distribution. That's a normal, very widely used prior distribution for regression model. As you can see, the model update procedure is a recursive one, so we can see that at each step we have actually a closed form solution and should be very easily to be computed at the local level. However, there is a key disadvantage of the sequential update approach, namely, we we have to, at the beginning of the learning procedure, we probably have to have a finite number of prefix number of devices already in our pool. So it's not very easy to update such a update procedure after some new devices are added later on. And such a learning procedure has to, because it has to be done sequentially, so it cannot, the update procedure can be delayed in some sense. For example, if I'm in the later queue of this update procedure, I may not benefit from the update until the first N-1 devices have been updated. So to resolve that problem, here we have proposed another federated learning procedure, still based on Bayesian approach. We call it hierarchical federated Bayesian learning. Here is based on hierarchical Bayesian inference. Based on the diagrams you can see here, now the learning can be done basically iteratively by 2 steps. At the first step, at the server stage, we update the model parameter or hierarchical parameters of the hierarchical Bayesian model phi 0 or phi naught by a EM procedure based on the updated parameters phi at the previous step. And the learning does not stop here. And after we update the hyperparameter phi naught, that basically the prior distributions parameter, we will propagate it to the individual distributed sites. And at each site I, then we will update the local posterior conditional on the hyperparameter, again in a closed form. And such a procedure, detailed procedure is listed in the paper. And the EM procedure that we have derived, the details of the EM algorithm and the derivation and proof are also listed in the paper. So in this way, we remove the requirements of a sequential update, but the update is more in a parallel flavor. To evaluate our proposed methods, we have, as I have said before, we are targeting at heart rate prediction problem. Here we have used a dataset containing 10 subjects. It's a real-world dataset obtained by wearable devices, a smartwatch, and the subjects are required to do outdoor exercises, basically running, and we collect the heart rate and also the speed. And here are some summary of the dataset. We got different basically subjects ranging, have different ages, height, weight, and BMI as well, to artificially generate some heterogeneous generality across the subjects and across the dataset sites, across the different sites basically. And to evaluate our method, we compare 2 baseline methods. We call them Fed average. That is a simple average-based federated learning algorithm. That is one of the state of arts in federated learning. So in this way, there is no formal statistical model behind it, but a simple average across the model parameters is used as a global model. And we also have listed another method that is called hierarchical Bayesian MCMC method. So here we have used a sampling-based equivalent of Bayesian inference procedure that serves as a baseline to comparing with our proposed Bayesian inference procedure, basically. And of course, we are going to compare the 2 different update procedure, sequential and hierarchical. These are the FD sequence Bayesian and FD hierarchical Bayes EB are the names we gave for our 2 proposed methods. And we compare over 2 metrics. One is error over time and error over user. The difference between them is for error over time, we basically compare the mean squared error over each time instances across different users. And for the user, we pool the data across users or subjects or sites if you want, and we do the average over the users. Here are the first result. We have basically 3 columns here: training error by user. The first row are the error or mean squared error by time instances, and the second row are the error by user. And the first column are the training error, the second is test error, and the third is new exercise error. The difference between test error and new exercise error is test error and training error are data from existing exercises. And new exercise data are those data that is totally in a new regime of exercise, that is, has never been trained, has never been used, or never been seen by the training algorithm. So basically, for the new exercise data, each exercises with even by the same subject has some different variations. Basically, that's has it, and should be more difficult to train or to predict in the prediction sense. And here we have listed the 4 comparing methods. The red and orange ones are the proposed method by us. And the dark blue one here is a simple benchmark, the federated average learning, the state of art. And also the yellow one is the sampling method, which is not federated learning, basically. As you can see, across all 6 different experiments, for training error and testing error, the federated learning approach proposed by us achieve a much better result. For example, for training error, the hierarchical federated learning approach achieved the best result, and the sequential update achieves a better result, actually comparing with the simple average, regardless of whether it's a training error or test error. And in terms of new exercise error, we can also see that the federated hierarchical Bayesian approach achieves the best prediction error as well. To better understand the benefits of Bayesian approach, here we have designed a new experiment we call imbalanced dataset scenario. So for each site, we use different number of data sets or different number of exercises, which is common in real-world scenarios. For example, if I exercise a lot, of course I have more data sets available. But some people, he may not have exercised. He might just use this like new devices, totally new to the exercise, to running. Then he does not have any new data set. So this is quite common in real world scenarios. So here we check whether our approach can handle this imbalanced data set scenario. As you can see, the simple average method totally fair in all different categories. For training error, test error, and the new exercise error, the imbalanced scenario for the simple average method deteriorates greatly comparing with the balanced data set. So in another way to put it, the simple average method federated learning works, but only works in some greenhouse condition, like not realistic in real world scenario. For example, only works when data is balanced. However, all other federated learning proposed methods, together of course with the Bayesian approach by sampling, achieve more robust results. That the method actually is more resilient to imbalanced data sets. So to conclude, In this work, we have adopted a Bayesian approach to do federated learning. So because we have used a Bayesian approach, we automatically inherit a lot of advantages of Bayesian methods. For example, that handling of imbalanced data is one example of Bayesian approach, and also feature selection, automatic feature selection, for example. And also the most important selling point of our approach is our approach can preserve privacy for IoT applications or pervasive computing applications. So in terms of future work, we are going to use our method to apply our method on more data sets, not only heart rate prediction per se, but also we'd like to adopt more sophisticated models. Here we have only used ARX model, but we'd like to see whether our Bayesian approach can handle more complicated models. So this is my talk. Thank you very much. I'm now happy to take any questions.
again, hope you have enjoyed the conference as much as I do. And this year is great thrill to see so many exciting research projects going on. We have many submissions in the important topics, which has shown the trend of future mobile health research. And this includes the remote health assessment and how we design better, secure platform for public health systems, and also different mobile sensing technologies and systems to enable early detection of neurological disease, mental health problems. Also, we have seen new machine learning techniques for enabling prediction on time series data and also for federated learning. Based on the quality of the paper and from the consensus of the committee, we are pleased to announce the Best Paper Award goes to Design of a Mobile-Based Neurological Assessment Tool for Aging Populations. The authors are John Templeton, Christian Polabor, and Sandra Schneider from the University Lausanne. And that we conclude our Mobile Health 2020. In the end, we would like to thank all the authors, TPC members, and EAI again, and hope to see you all again at next year's Mobile Health.